Session. For this, speaker is the great orator, Dr. Kushagrati Ghosh. Topic is silent feto-maternal hemorrhage and Rh negative prophylaxis guidelines. For this session, I request Dr. Supriya Jaiswal to kindly chair the session. You are requested to come. Next is Dr. Nutan, Dr. Poonam Lal. She is consultant at Kurji Holy Family Hospital. She has great interest in academics. Now, mic is yours, sir.
Silence, please. Stand long between you and the lunch and between me and the flight. So I think we'll cover everything in 10 minutes. I won't be fast, but I'll be skipping slides maybe. So we are going to talk on silent feto-maternal hemorrhage and Rh prophylaxis. Now, when we talk of blood group antigens, we know there are ABO antigens, there are Rh antigens, and there are minor antigens, like Kell, Duffy, and Livy. We say the Kell kills, the Duffy dies, and the Livy lives. So what happens with D antigen? That is the one which we are talking about. And what happens with D antigen is Rh alloimmunization. Alloimmunization is basically immunization because of some antigen of the same species. When it happens to one's own body, it is called autoimmune. And when it happens to a different species, it's called xenoimmunity. So basically, alloimmunization is because of one human antigen causing antigenicity and antibody production in different individual of the same species. So where does this antigen come from? The antigen comes from the fetus cells. And where does this fetal D antigen come from? It comes from the father. So when these cells, the anti-T cells enters the mother's maternal circulation, the mother produces antibodies. So biological father of fetus is the one where the fetal antigen comes from. And if the father is heterozygous, then 50% of the fetuses will be Rh positive. And if the father is homozygous, then 100% of the fetuses will be Rh positive. Then when these Rh positive cells enter the maternal circulation, antibodies are produced. And this is called Rh incompatibility. And these antibodies, they stay in the maternal circulation and they produce fetal anemia. Now this fetal anemia does not happen in the first pregnancy, because the one which is produced is mostly IgM, and then that does not cross the placenta. And this sensitization occurs and the antibodies stay. Now when the patient becomes pregnant again, and if it happens to be an Rh positive fetus again, then there is a secondary response, and this antibody crosses the placenta and then attacks the RBCs of the second fetus usually and causes hemolysis. So this anemia, what the fetus has, is basically fetal hemolytic anemia. Now, this hemolysis behaves in two different ways in fetal period and neonatal period. In the fetal period, what happens is anemia occurs because of hemolysis, reduction in the red blood cells, and because the hemoglobin goes down, the oxygen carrying capacity goes down, the tissues suffer from hypoxia, the fetal tissue suffers from hypoxia, the heart tries to pump more blood by increasing the heart rate and the cardiac output, and in doing so, the heart fails and it produces congestive cardiac failure, as is evidenced by waterlogging everywhere in the forms of hydrocephalus, polyhydramnios, placentomegaly, etc. And when the hypoxia occurs further, it happens in fetal death, intrauterine fetal death. That is happens before birth. Now, before birth, this hemolysis obviously produces bilirubin. Any hemolysis will produce biliverdin and bilirubin. And bilirubin has to be excreted. Now, in fetal liver is premature. So this biliverdin to bilirubin to sulfated bilirubin cannot occur by the fetal liver. But still, the fetus never has jaundice. So in spite of such severe hemolysis, the fetus does not have jaundice. Why? Because this bilirubin is excreted through the placenta by the mother. So the mother works like the kidney of the fetus. But in the neonatal period, what happens is this hemolysis will obviously produce anemia as well as hyperbilirubinemia. So in the fetal period, the baby dies because of anemia, and in the in the neonatal period, the baby dies because of hyperbilirubinemia. So the same pathology causing two diseases in two states of the life. So that's what happens with intrauterine fetal death, and that is what it happens. It happens with jaundice, with anemia, with hepatosplenomegaly because long-term reticuloendothelial system stimulation, heart failure, kernicterus. Kernicterus is basically convulsion due to hyperbilirubinemia. In fact, our professor in PGI pediatrics used to say that if a hyperbilirubinemic baby has a convulsion, it is better for the baby to go, because these babies will almost 100% have cerebral palsy. There is no record of any kernicterus baby having a normal life. It is so serious. So that's why we should be very careful in not allowing a hyperbilirubinic baby to have even a single convulsion. And then of course, if there is conversion, there is 100% chance of mental retardation, which we call cerebral palsy. Now, the main problem with Rh albumination is sensitization. So this sensitization has to happen, which is the first inoculum of D antigen which enters the fetal and the maternal circulation, and it can happen with as low as 0.1 ml. The time where sensitization occurs is most common immediately after childbirth, but immunization can happen all throughout pregnancy. In the first trimester, it is less. In the second trimester, it is middle. And in the third trimester, the chance of immunization is more. So there are different reasons why immunization can occur, like the most common is in the delivery, but threatened miscarriage, complete miscarriage, MTP, and especially in cases of MTP pills, which are available now, the mother is Rh negative, father is Rh positive, and they have an unplanned pregnancy. They go through taking abortion pills, and there is no monitoring of ICT. These are the cases, maybe because of what this incidence of ICT positive is increasing. There is invasive procedure like amniocentesis and CVS, which we don't give, and which if you don't give anti-D, then there is a problem. Ectopic pregnancy, molar pregnancy, even in IUFD. Some people think that in IUFD you don't need to give anti-D, but that is wrong. But on top of these, there is a silent fetal-maternal hemorrhage, which occurs throughout pregnancy. And non-fetal exposure is very rare, because these days we are not giving Rh positive blood to Rh negative patients anyway. So what is the management of Rh negative mother? Once we find that the mother is Rh positive, we do a test which is called ICT, indirect cum test, which is an immunoglobulin test to see whether the mother is immunized or not. If the ICT is negative, we call the mother non-immunized. If the ICT is positive, we call it immunized. As simple as that. Now, once the mother is ICT positive, there is no role of anti-D at all. There is no point in giving anti-D injection to a mother who is already ICT positive. Now, the management of Rh are non-immunized mothers, which means a mother has come with Rh negative, we do an ICT, and the ICT is negative. What to do? So next thing, the next time when we should do the ICT is at 28 weeks. Now, how to deliver an Rh negative mother? First stage, we do CTG. Second stage, uterotonics after delivery, because there is some confusion. Some people used to say that if there is an Rh negative mother with an Rh positive fetus, who is ICT positive fetus, Rh negative mother, ICT negative, non-immunized, and the fetus may be positive or negative. So after delivery, you don't give uterotonics, you don't massage the uterus, all those things used to say, because there will be more fetal-maternal hemorrhage, but that is wrong. We need to follow the active management of third stage of labor, because life of the mother is more important. Prevention of PPH is more important than all these theoretical stuff. So delayed cord clamping is avoided, because we want the uterus to contract as soon as possible. Length of the cord has to be kept 5 centimeters, because in case you need a exchange transfusion. In third stage, no massaging of the uterus. And in cesarean section, we need to remove as much as blood as possible, because there is a placenta. If we cut, especially separation of the placenta, there is always fetal blood, and that fetal blood, if it enters into the Rh negative mother in the abdominal cavity, then even after we close the abdomen, that Rh positive blood keeps on getting absorbed in the maternal circulation, and that increases the fetal-maternal hemorrhage. So so-called fetal-maternal hemorrhage, and the amount of anti-D which we give may not be sufficient to provide complete immunoprophylaxis. So that's why we also avoid manual removal of placenta, especially we have a habit that after cesarean section, we quickly remove the placenta by hand, and that is something which needs to be avoided, especially in a case of Rh negative mother. And we have to collect cord blood for certain investigations. Standard protocol is to carry, you collect 5 ml of clotted blood for Rh, ABO, antibody, ABO, Rh blood group of the baby, the direct cum test of the baby, and serum bilirubin, conjugated or and unconjugated. And we take a 5 ml of EDTA blood for hemoglobin and packed cell volume and reticulocyte count, because reticulocyte count actually shows the degree of hemolysis. And then in theoretically we should be doing a Kleher-Betke test, which we don't do. Now, I won't go into the Kleher-Betke test, but what we should come to is, if there is an Rh negative mother, we have given repeat an ICT at 28 weeks, and we basically deliver with all these precautions, and we collect cord blood for these investigations. But apart from that, what is important for us to understand about this 28 weeks anti-D prophylaxis, because in majority of cases, we don't give this antepartum prophylaxis. That is something which we need to understand. This sensitization can be prevented very much by giving anti-D antenatal prophylaxis, which is called RAADP. Now, anti-D, when we give injection, is a passive immunization. What it does is, if there had been any fetal blood which has entered the maternal circulation, by giving anti-D, we cover that fetal blood, all the Rh isotopes, so the mother's reticuloendothelial system cannot recognize and therefore does not produce antibody, and they are enucleated and excreted. So that is the whole idea of anti-D injection. So routine anti-D prophylaxis has to be given to whom? We need to give it to an Rh negative mother with an Rh positive father who has an Rh positive, Rh negative, ICT negative pregnancy. Now, the mechanism of action, we have gone into how anti-D works, and there are 3 types of anti-D: polyclonal antibody, anti-D, monoclonal antibody, anti-D, and recombinant anti-D. The polyclonal anti-D is no more available in India. Monoclonal antibody and recombinant anti-Ds are available in India. The polyclonal anti-D, you must have heard this trade name. So this is what this was produced by a pooled human sera from different types of individuals. It used to carry lots of allergic reactions and also chance of infection. So it is not available anymore. The next came this particular medicine, which is by hybridoma culture and with a technique in the lab where it is semi-synthetically produced with a hybridoma technology, with a hamster egg, etc., etc. There is very less batch-to-batch variability, more consistent, and less chance of reaction. And now is the one which this is the one which is recommended now, and this all of us should be actually using anti-D. It is trinbelimab, and this is an injection which contains 300 micrograms of anti-D. I think now 150 microgram is also available. This is for information. It has been available only in last 2-3 months. So we don't, and it is cheaper also. So previously 150 microgram was not available, but now 150 microgram is available. So anything before 28 weeks, if we have to give anti-D, we can give 150 microgram, like for example, after every amniocentesis, CVS, or EBER reduction, or early pregnancy bleeding, MTP pill, or whatever, ectopic pregnancy, nowadays we give anti-D 150 microgram, which is available. If it is not available in any center, you can always ask for it. Otherwise, 300 microgram after that. So advantages of recombinant anti-D is obvious the need for serum products. It is obtained from serum-free medium. It quells the concern of transmission of infectious diseases. It avoids the problem of cell line changes, which was there in the monoclonal antibody. Because when there is a culture, what can happen is one of the few cells can go bizarre and produce a different type of culture, and the anti-D produced from that may not have that sensitivity. So that is what is called batch-to-batch inconsistency, though that is much less compared to polyclonal antibody, but still monoclonal antibody has some of that effect. But this recombinant anti-D, which is available as anti-D generic name, which something which does not have. And recombinant provide better yield also, because you can produce in the lab in whatever quantity you feel like. So this is the recombinant anti-D, 300 microgram, which in units it is 1500 units. It's a single use IM injection in deltoid, not to be given in the gluteal region. It has to be given within 72 hours of delivery. 300 microgram anti-D neutralizes 30 ml of fetal Rh positive blood. Don't have to remember that. And if the fetal-maternal hemorrhage is less than 5 ml, it gives 95% protection. But for practical purposes, we give a single dose of anti-D, because if there is an excess bleeding, we think, like for example, twin pregnancy, cesarean, PPH, etc., sometimes there may be fetal-maternal hemorrhage more than 5 ml, but then we don't have any calculation method, so more or less we give one injection. Hardly ever we give 2 injections. So what is important for us to understand, it's not that all cases of Rh negative mother with an Rh positive fetus will develop sensitization. It's only 16% it is there, that if you don't give anti-D, only 16% will get immunized, rest 84% will not. So why these 84% don't get sensitized, we don't know. They are quite capable of neutralizing fetal RBC and not getting sensitized. But if you give postpartum prophylaxis only, without giving antenatal prophylaxis, just one injection after delivery, then we reduce it by 90%, which comes to 1.6%. But that also these days is quite high. That's why this antenatal prophylaxis has come, by which it is reduced to further 90%, which means 0.16%. Which means if we don't give any anti-D at all, 16% will get sensitized. If we give one injection in the postpartum period, 1.6% will get sensitized. And if we give antenatal always postpartum, then 0.16. Antepartum, we don't know whether the fetus is positive or negative. So therefore, any mother who is Rh negative and ICT is negative, we routinely give anti-D prophylaxis at 28 weeks. The postpartum dose depends on the blood group of the baby. If the blood group is negative of the baby, then we don't give anti-D to the mother. And if the blood group is positive of the baby, then we give anti-D to the mother. And the other thing is that if the ICT is already positive, then we don't give anti-D at all. So that is the take-home message. Now let us come to the FOGSI guideline, the last 2 slides. This is the FOGSI guideline, which we should all follow. You can always take a picture also if you want. All Rh negative women should have an ICT for screening in the first visit. After that, if it is negative, then we do a repeat ICT at 28 weeks. In case if the woman has had antenatal anti-D, subsequent ICT is not performed. If ICT is done after anti-D prophylaxis and the result wrongly done, and if by chance it comes as positive, then there is a confusion whether it was due to active immunization or passive immunization due to the anti-D that we have given. And we really need to go then to MCA PSV Doppler to see whether the fetus is anemic or not. If the fetus is becoming anemic, that means it is due to active immunization. If it is normal, then maybe it could be the passive immunization and the baby will not be affected. But in these cases, it is better to refer to a fetal medicine center. And documentation of blood group of the baby and the ICT status of the neonate must be done. And the DCT. Rh negative women, we have to understand, may have silent fetal-maternal hemorrhage in the 3rd trimester, which is more common. That's why we give the anti-D at 28 weeks. In UK and USA, they give 2 injections at 28 and 32 weeks. In our country, we give it at 38 weeks. If you miss the 28 weeks, you can give it at 30 weeks, 32 weeks, but please give 1. In order to protect against this, antenatal anti-D prophylaxis was introduced, which reduces further by 90%, as I said. A single dose regime of 300 microgram IM in the deltoid, not to give in the gluteal, because majority of the anti-D is not utilized then. It is economical and often has a better compliance. A single dose regime is equally effective. Some results have shown as the 2-dose regime. RAADP should be given only if the ICT is negative at 28 weeks, not to give anti-D injection without doing ICT. So that is what it is, and that is the detailed thing. If somebody wants to go into it, I just simplified into that 2 slides. Thank you very much. I won't go into, I won't go in if it becomes positive, because anyway there is no time. This one.
Previous slide. For your excellent and illuminating talk, you have rightly said that silent fetal hemorrhage is less common, but it is very dangerous. Sometimes it is moderate to severe and can lead to fetal anemia and death. So every patient should receive antenatal prophylaxis. And again, in postnatal, you have said even in IUD patient it should be given. That was take-home message for us. Thank you, sir.
Thank you. Wonderful presentation, sir. Thank you. Thank you very much.
In NMCH, and of course she has got a lot of इनका CV दिखाना. And then I invite Dr. Neelu Prasad. Please come to the dais. Thank you, Dr. Neelu. Thank you, Dr. Amita. Now over to the chairpersons to conduct the session. नहीं पहले आभा दिखा दीजिए ना आभा दिखा
Now in post-lunch session we will have one very important lecture, and speaker is none other than Dr. Abha Rani Sinha. दिखाइए slide दिखाइए. Abha Rani Sinha madam is principal SKM CH Muzaffarpur. She is ex-chairperson quiz committee Foxy, and madam is past president Patna, recipient of so many awards, and madam is going to talk about inverted pyramid of antenatal care. Madam, over to you.
Hello. So thank you, chairpersons, for your very generous and kind introduction. And so now I'm going to talk on inverted pyramid of ANC. I know it's a post-lunch session, so I think all of you must be feeling sleepy. But just I would like to give the concept of inverted pyramid of ANC. We all know the objectives and aims of ANC, that is to screen the high-risk cases, to prevent, detect or treat at the earliest any complication, and to ensure continued medical surveillance. And before that, this was the pyramid, the old model which we were following when we were MBBS students or when we were doing our post-graduations, when we were giving more and more emphasis to antenatal care in the last 4 weeks of pregnancy. But now we have an inverted pyramid where the 11 to 13 weeks is the most crucial part of the antenatal care. Why? Because important complications that occur later in pregnancy can be predicted in the first trimester. So now, what is the advantage of having an inverted pyramid of ANC? We can do early screening of fetal aneuploidies. We had a very good lecture in the morning. Early diagnosis of fetal abnormalities, early screening of preeclampsia, fetal growth restriction, preterm delivery, and also first trimester assessment of multiple gestation. So the first thing for screening for fetal aneuploidy, we know that the gold standard is combined test, which combines nuchal translucency along with 2 important serum analytes like PAP-A and free beta HCG. It has a detection rate of 85% with a false positive rate of 5% for trisomy 21. But the only disadvantage is that it cannot screen the neural tube defects. If we want to increase the effectiveness of the combined screen, we can further augment it by addition of other parameters like nasal bone evaluation and Doppler evaluation of the ductus venosus and the tricuspid valve. As we had learnt in the morning, that nuchal translucency alone is not a very good test for fetal aneuploidy because it has got a less detection rate, that is only 1% if it is taken as a single measurement. The other point with nuchal translucency is that it requires a good machine as well as a good operator. It is operator dependent. A person who is certified by the Fetal Medicine Foundation, that person can only come up with a proper nuchal translucency measurement. So, if we combine the nuchal translucency with measurements like maternal age and serum markers, then only we have a good detection rate of fetal aneuploidies. Now, contingent protocol, as Dr. Kushagrati Ghosh has said, it's out of, now it's not the evidence-based thing to do, but still, if we get a report, like if it is 1:51 to 1:1000, initially we used to go with the quadruple test, but I will not go for it because we are not doing it at this moment. It is out of practice. So now, what are the advantages of combined test? The best thing is that it is done in the early weeks of pregnancy. That is between 11 to 13 weeks. So that is the time when we can make a decision. Like if we want the baby to be aborted, abortion will be safer and the trauma to the mother will also be less. On the other hand, the disadvantage is that we know that many of these Down syndrome babies, they will be a natural loss. Many of them will not go up to the second trimester. So it will be causing an undue anxiety to the mother and it may not be of any help. Now comes the enhanced first trimester screening. That is, along with the combined test and the serum analytes like PAPA and beta-HCG, we can add other markers like placental growth factors and maternal serum alpha protein. And if we add these to the first trimester markers, then it becomes an enhanced first trimester screening. Quadruple test, again, this is the test we may have to do, because what happens, many of our women, they come late for antenatal care. So at that time, we miss the opportunity of doing a combined test. For these women, the quadruple test is the test to be done, which includes 4 markers. We all know that is HCG, alpha fetoprotein, unconjugated estriol and inhibin. And it can be done at a later time. And it does not include any ultrasound marker with it. It is purely a serum-based marker. Now now the integrated or sequential, again, this concept is now no more important, but at least for the benefit of PG students, I would like to say that this is a test where we integrate 2 tests. That is, first time we draw blood for NT and combined test, and we do not disclose the results. If it is a low-risk result, we do not disclose the result. Then we do a second sample again as the time of the quadruple test, and then we integrate the 2 results, and then we disclose the result to the patient. However, if it is high risk in the first test only, then we disclose the result to the patient. Integrated test is same, but it is without nuchal translucency. It only takes the serum values. Now the thing which is very much in is the cell-free DNA. We don't call it now NIPT, we call it NIPS, because it is still a screening test. We have to understand it's not a diagnostic test, it is a screening test, and therefore we call it non-invasive prenatal screening. And this has got a very high sensitivity for trisomy 21, and it also detects sex chromosomal aneuploidies, and it is reasonable to use for secondary screening. Like if we have a doubtful result, then in that case we can do with NIPS, but again we have to understand that the pre-test counseling is very important, because this is still a screening test and the diagnosis can be made only by an invasive test. The other important part of early antenatal care is early diagnosis of fetal anomalies, because we all know that detailed evaluation of fetal anomalies is an integral part of first trimester ultrasound. Initially, it was just only about knowing the gestational age, knowing about the viability of pregnancy, but now the 11 to 13 week scan can tell us about many anomalies and also the nuchal translucency thickening. Like these are the different anomalies of head, face, neck, spine, thorax, abdomen, limbs, placental and umbilical cord, which can be diagnosed as early as 11 to 13 weeks, and therefore we can help these mothers by terminating the pregnancy if it is a anomaly which cannot be rectified or which is which does not lead to a viable fetus. Now, nuchal translucency, apart from being an aneuploidy marker, it can be associated with structural defects such as diaphragmatic hernia, omphalocele, facial clefts, body stalk anomalies, skeletal defects, congenital adrenal hyperplasia, fetal akinesia, and many syndromes like Noonan syndrome. And the risk of congenital heart disease also increases with increasing nuchal translucency measurements. So if the combination of three markers, that is nuchal translucency more than 99 percentile, tricuspid regurgitation, and abnormal A wave results in a detection rate of 52% of with a false positive rate of 4.1%. Now the other area where we do a first trimester screening, which is very important, is for prediction of preeclampsia. And it is important that we do early prediction of preeclampsia because that will help us to go for a tailored prenatal surveillance to anticipate and recognize the onset of clinical syndrome and manage it promptly. Even FIGO nowadays says that there should be strategies to screen for PE not only in high-income countries but also for low-resource countries. And this can be done by a first trimester combined test with maternal risk factors and biomarkers as a one-step procedure. And there is a risk calculator which is available free of charge at this website, https://fetalmedicine.org, research assess preeclampsia. If you go to FIGO website, you will find this site, or this can give you a risk calculation mechanism. So now what are the combined tests for prediction of preeclampsia? It is the maternal risk factors, the measurement of maternal arterial pressure, the serum placental growth factor, and the uterine artery pulsatility index. If all these four are combined, then we get a high detection of high prediction rate for preeclampsia. Risk factors, according to NICE, we all know that if there is any one major factor like history of hypertensive disorder, chronic kidney disease, autoimmune disease, diabetes mellitus, chronic hypertension, or multifetal gestation, these are the risk factors which help us to predict or help us to screen those women who are going to develop later preeclampsia or eclampsia, or any of two moderate risk factors like first pregnancy at the age of 40 years or more or less than 19 years, interpregnancy interval of more than 5 years, family history of preeclampsia, primary paternity, or if the patient is very obese, or IVF pregnancies. Now these risk factors, they have been described by various professional organizations for identification of women at risk of PE, but this is not a very effective. Alone, if we only take the maternal risk factors, they are not very effective for predicting preeclampsia, because the NICE guidelines, they say that the detection rate for preterm PE only by risk factors is 39%, and for term PE it is only 34% with a 10.3% false positive rate. So now what, if we take the history and the examination findings, this I think all of us should know, and all of us should have this copy on a table, because this is the gestosis score, and gestosis is mainly this scoring is mainly done by Indian authors and by Indian researchers. So at least this gives us a guide that how do we know that this patient can develop later on preeclampsia. So this, there are 3 scores for every clinical risk factor, or depending on the history or on the examination, 1, 2, 3. And when the total score is more than 3, then the women should be marked as at risk for preeclampsia. This is a very busy slide where we can see the gestosis score according to the history or according to the findings. So, the mean arterial pressure, again a very simple thing to do, but it should be always measured by automated and semi-automated devices, and it has got a detection rate of 47% if we are using it alone, or when used in combination it can be as high as 76%. Now placental growth factor is again those women who are destined to develop preeclampsia, they have a lower level of placental growth factor concentrations, and it has got a detection rate of 55% and 33% respectively at 10% false positive rate. If we compare all the biomarkers, what we find, there was a systematic review and meta-analysis which showed that placental growth factor is superior to other biomarkers for predicting preeclampsia. Specifically, maternal placental growth factor concentrations alone achieve a detection rate of 56% at 9% false positive rate. And now PAP-A is a part of combined test, what we do for the fetal aneuploidies. But if we look at its sensitivity in predicting preeclampsia, it's not very good. It is, as a single marker, it is not a very accurate predictive test because there was a large systematic review and meta-analysis which had shown an odd ratio of 1.94% and a detection rate of only 16%. Now the other important marker is the uterine artery Doppler, PI. We all know that abnormal uterine placental circulation can be observed in the uterine arteries by ultrasound from as early as the first trimester of pregnancy. And for this, we have to use a transabdominal ultrasound. The view is a sagittal section of the uterus. The uterine arteries are identified with the use of color flow mapping at the level of internal os. And the uterine artery PI and the peak systolic velocity is measured. And what we take is not the right or the left, but the average of both right and left PI, and that is used for the risk assessment. The first trimester abnormal uterine artery PI is defined if it is greater than 90 percentile. And this alone has a detection rate of 48% at 8% false positive rate. And for late onset, it does not have a good prediction rate. It is only 26%. So now there has been a model. That model is known as base-based model, where they combine all these things which I have spoken just now, the risk factors, the serum markers, and the uterine artery pulsatile index, and they have made a risk scoring. As the risk scoring for aneuploidy, there's also a risk scoring for this. And a woman is considered as high risk when the risk is greater than or equal to 1 in 200 based on the first trimester combined test with maternal risk factors, MAP, PLGF, and uterine artery PI. So this is that once you take all these measurements, you get a risk factor. If it is less than 1 in 100, it is considered low risk and the patient goes for a routine prenatal care. If she is a high risk case, then we have our intervention in our hand. Like for prevention of preeclampsia, we all know that we give aspirin. The initial dose was 75 milligram, but these days it is 150 milligram. Though it is debatable in women with low BMI, the dose can still be 75 milligram, but what the guidelines say, the dose for preventing eclampsia or preeclampsia is 150 milligram. Contingent screening, like what happens that in low resource, whenever we talk, we can talk of high things, like uterine artery PI for all patients, serum markers for all patients, but we know that we are residing in a low resource settings. Or many of our women, they do not have an access to high resource settings. So in those cases, we can just start with doing two things. That is, we take the maternal risk factors as well as the MAP, which is easy to measure. And then after that, we then divide these women into low risk or high risk. The low risk, they go for the usual antenatal care. And if they are high risk, then we ask these women to get the serum testing done. We can just see this. Like initially, it is only the maternal factors and MAP. If it is screen positive, we go for the second stage screening, that is PLGF and uterine artery PI. And if it is screen positive, we know that these patients are destined to develop preeclampsia. And if it is screen negative, they go for the usual antenatal care. And of course, prevention may, apart from aspirin, we also know that since our women, mostly they are calcium deficient, so we have to give them calcium 1.5 gram daily till delivery. And these patients, they need more intensive monitoring as well as surveillance. And it was found that when this two-stage screening was done, it has got a high detection rate of 71% with a false positive rate of 10%. And if we look at the detection rate of both early as late PI, the combination of all these factors gives the maximum result for prediction. Now coming to small for growth gestational age babies, this can be also detected or predicted by an increase in uterine PI and maternal mean arterial pressure. Apart from this, we have other markers like PAP-A, free beta HCG, PLGF, PP13, that is placental protein 13, 8 disintegrin, and metalloproteinase 12, that is ADAM12. They all increase the risk of SGA. Most of these are only in research settings. What we are doing in a clinical practice is PAP-A, which we get along with the first time combined test, and placental growth factor. The for a false positive rate of 10%, if we are using all these markers, which is not practically feasible, we can identify about 75% of SGA fetuses delivering before 37 weeks and 45% that deliver at term. The other important part of inverting the pyramid of antenatal care is to screen for preterm labor. Cervical length measurement, as we talked earlier also, that at the time of anomaly scan, if we are measuring the cervical length, we can predict those women who are at high risk of going into preterm labor. And these high-risk women, they may benefit from close follow-up and possible treatment. The other important area of first trimester assessment is for multiple gestation. We all know that chorionicity is very important when we are planning any of these multifetal pregnancies, and to perform any accurately prenatally invasive procedures and also to manage complications such as twin-to-twin transfusion syndrome and selective IUGR. We can see that the twin peak sign is usually in the diamniotic dichorionic twins, and in monochorionic twins we get the typical T sign. So these are very reliable sonographic signs, the lambda sign and the T signs, and also the number of placentas. So whenever we are doing a scan for 11 to 13 weeks in a case of multiple pregnancy, I think we can prognosticate the case, we can know the complications that these pregnancies can have, and we can accordingly, we can plan our monitoring and surveillance of these patients. So at the end, I would like to give certain key messages that first trimester screening and diagnosis of fetal aneuploidies helps patient become aware of these conditions early in pregnancy, where they can make the decision for termination of pregnancy. And when we compare the combined screening and the cell-free DNA technology, we have to understand that both are efficient screening tests for aneuploidy early in pregnancy, but cell-free DNA is more accurate. So as said rightly in our morning lecture, that if the patient is an IVF pregnancy, or if the patient is a case of recurrent pregnancy loss, or if there is a family history, or if there is any genetic abnormality, it is better to go for the cell-free DNA first as a screening test. Why to spend on 2 tests? Then in those cases, the cell-free DNA test will be a better test. Therefore, cell-free DNA technology should not be a replacement for the traditional first trimester screening. Next, only last slide. Screening for gestational hypertensive disorders, we are all seeing multiple cases of eclampsia still in our labor rooms. I don't know about PMCH, but in SKMCH, I think every day we are getting cases of eclampsia. So we need to do something to prevent these pre-eclampsias and eclampsias, and start prophylactic medications. And of course, in multiple pregnancies, if we have an early ultrasound, we can definitely salvage these fetus or prevent the complications. Thank you so much for a very patient hearing.
Thank you, madam, for your nice and elaborate presentation on inverted pyramid of antenatal care. You have very nicely mentioned about all the conditions that can be detected in early first trimester by early screening. So thank you so much.
Thank you.
And audience, if you have any question, you can ask.
So one thing very good and eye-opening all the speeches from ma'am, and 2 things I would like to add in this. Nowadays, most of the pregnancy, due to the age, there is so many complications in there. So what our aim is to deliver a good baby and take home baby and safe delivery. So for this, we have to do all the basic investigation, especially at the 11 to 13 weeks, to know any congenital anomaly and all other tests, so that maternal complication may be reduced. And these are the tests definitely done by all the obstetrician and gynecologists for the good outcome of the pregnancy. Thank you.
Okay, thank you, thank you.
Thank you, Chairperson, and also organizer for giving me this opportunity. Today my subject is peripartum hysterectomy. It is defined as hysterectomy performed as a life-saving procedure at the time of delivery or up to 6 weeks postpartum period following cesarean section or vaginal delivery. INOS, International Network of Obstetric Survey System, says that surgical removal of uterus from 22 weeks of pregnancy up to 42 days of postpartum period is called peripartum hysterectomy. The golden year was 1871, performed by Poro, which we have learned the history from the last lecture by our chief guest. The incidence is due to past disorder. Worldwide it is 71.6% to 82.61%. Foxy says that 10 to the 5 power delivery, but in India it is 0.24 to 89 per 1000 delivery. The incidence is increased in developing country due to increased population, increased birth rate, and lack of proper monitoring facilities. So there is increase of cesarean section, placenta previa, and increased placental spectrum syndrome. Obstetrician should be aware of difficulty of emergent condition and improve its antenatal ANC diagnosis rate, and expert skill is required. Also in where altered hormonal milieu occur, especially in the IVF, where the increased estrogen level, elevated estrogen level at the time of implantation causes increased trophoblastic invasion deep inside the myometrium. And if the estrogen is low, the presence of thinner decellularized endometrium may cause PAS syndrome. This is the cause of PAS placenta accreta and praticata in primary gravida with advanced age of IVF pregnancy. Cryopreserved embryo increase 4 to 13 times risk of PAS disorder. The commonest indication of peripartum hysterectomy is uncontrolled uterine bleeding following delivery. The causes are uterine atony due to age, due to increased parity, due to PAS disorder, uterine rupture in previous cesarean, sepsis, injury to the uterine vessels, extension of cervical tear, and chorioamnionitis. The indication of peripartum hysterectomy according to time of surgery, it may be emergency, indicated, or elective. Anatomically, it is supracervical, subtotal, total, or radical. Clinical indication planned, diagnosed preoperative period by ultrasonography in PAS syndrome, emergency occur in PPH, and postpartum perihysterectomy is done due to sepsis. This is a question mark of salpingo-oophorectomy, depends upon the age of the patient. If generally the patient are younger, tubes ovaries usually left. But if it is anatomically distorted, salpingo-oophorectomy is performed. Management depends upon diagnosis, investigation, and treatment. Diagnosis, antenatal period, ultrasonography is gold standard, highly accurate, color Doppler, 3D power, increased sensitivity. MRI is done to assess the depth of myometrial invasion and parametrial involvement. Biomarkers, important tool for PAS as it is altered. From 11 to 12 weeks, beta HCG lower, papa is increased. And from 14 to 20 weeks, elevated maternal serum alpha fetoprotein, beta HCG is lower, and papa is increased. In even the intraoperative period, when we open the abdomen, we can see that there is presence of engorged vessels in the lower segment, just like earthworm. It is a good indication of placenta previa and percreta. So clinical criteria also to diagnose this placenta accreta, possibly predictive in clinical sign are difficult manual or piecemeal removal of placenta, absence of placental separation 20 to 30 minutes after delivery despite active management, retained placenta fragment require curettage, and severe bleeding from placental bed. Then we become alert. Prerequisite for peripartum hysterectomy, must be multidisciplinary approach should be there. Blood bank, including availability of alternative blood products, experienced obstetrician and accompanied by pelvic surgeon, urologist, interventional radiologist, ICU facilities, NICU, and most important is written and informed consent of guardian should be taken before doing peripartum hysterectomy. Investigation as in other hysterectomy, CBC, ABO, RH, coagulation profile, and preoperative requisites are 2 central lines should be placed, 2 large bore IV needles should be used, and maintain catheterization, urethral catheterization, and ureteric to prevent injury to the bladder and ureter intraoperatively. Points to be highlighted, While doing procedure, anesthesia is epidural plus spinal. Incision of skin is vertical skin incision preferred for adequate exposure. Many times transfers has to be converted into Maillard's incision for better exposure. Peritoneum should open high up to prevent injury to the urinary bladder. Separation of round ligament is done, so the broad ligament is open. Dissection of bladder, all the dissection of bladder and perivascular space is done. All the palpation, clamping and separation of cardinal ligament, uterine arteries is done. Separation of uterosacral ligament, all ligaments should be cut, should be diagnosed, cut and sutured. Closure of the vaginal cuff is done just like other hysterectomy. Here is a diagram showing uterus is elevated by placement of clamps across broad ligament including round ovarian ligaments. You can see the stumps are clamped, cut and suture is done. Difficulties which a surgeon can face intraoperatively: uterine size is big and space is restricted. Soft cervix difficult to identify. Lower segment elongated. Blood vessels engorged. Massive hemorrhage obscure the operative field. Tissue vessel wall edematous and may lead to losing of the ligature in post-operative period. Injury to the bladder can be prevented by filling bladder with 300 ml of methylene blue to identify the superior margin of the bladder. Ureter stent can be done to prevent injury. In emergency with an unstable patient, clamping of uterine blood supply rather than adenolysis and pedicles rapidly clamped, cut and dropped and subsequently sutured. In case of bladder invasion, cystostomy performed with resection of the affected portion of the posterior wall of the bladder and uterus is removed in block, followed by bladder repair. All post-operative patient, stable patient as in any other hysterectomy, but unstable patient need ICU care. Prophylactic antibiotic is given and thromboprophylaxis is done. This is the case study. A 35-year-old female, 6'3", para 2 plus L2 with 34 weeks of pregnancy, history of previous 2 LSCS, came with complaint of bleeding per vaginum, was referred from primary health care center. In ultrasonographic finding, placenta was anterior and low-lying. In color Doppler, hypervascularity was present, but these are inconclusive of placenta accreta spectrum. Patient was admitted and conservative treatment is given, bleeding is stopped, injection betamethasone 12 mg, 2 dose given. MRI suggested and MRI is done. Finding was placenta was anterior and lower segment with evidence of loss of retroplacental zone. Myometrial thickness is less than 1 millimeter and hypervascular placental legs suggestive of placenta accreta spectrum. As we know, women with previous cesarean section seem to have higher incidence of placenta previa and past disorder. During routine fetal anomaly scan, it should be specifically screened for as per new RCOG guideline 2018. Ultrasonography is highly accurate when performed by a skilled operator. Women with any ultrasonographic features suggestive of placenta accreta spectrum should be referred to a specialist unit with imaging expertise as per guideline 2018. Elective operation was planned by multidisciplinary team. A live preterm baby was delivered who was resuscitated by pediatrician and managed in NICU. Peripartum hysterectomy was performed. Total 4 units of blood was transfused. Patient was transferred to ICU and post-operative period was uneventful. As you can see in the diagram, the second case is a 32-year G3 para 2 live 2 at 18th week of pregnancy. History to previous 2 LSCS came to our tertiary care hospital at MGM hospital from some district hospital with ultrasound and MRI report. Ultrasound finding was placenta lower anterior, multiple cystic area with lobulated contour, loss of normal retroplacental hypoechoic area, increased vascularity on color Doppler, finding suggestive of placenta accreta. This is MRI. MRI finding anterior placenta in lower segment with loss of uteroplacental zone invasion of bladder was present. Finding suggestive of placenta percreta. Prognosis was explained to the patient attendant and they were not ready to continue the pregnancy. So planned peripartum hysterectomy was performed. Placenta was perforated in bladder. The parts of bladder along with placenta was removed and repaired. Follies kept for 21 days. Total 3 units of blood was transfused and post-operative period was uneventful. So to conclude, it is a life-saving surgery. Difficult and different, tissue soft and fragile, vessel dilated and distorted, quick and meticulous. So take-home message is, planned is better than emergency. Total hysterectomy is better than subtotal. A tertiary care with all facilities, avoiding uterotonic agents. It causes partial placental separation leading to severe PPS. So if you diagnose previously, then at the time of delivery, don't give uterotonic. Clamping and controlling bleeding at priority. Post-operative care is important. Diagnosis by antenatal imaging and multidisciplinary team approach for the management is the strategy. With prudence and preparedness, we can overcome the problem. So, saving life is more important than saving uterus. Thank you.
Very good talk, Rita Di. And especially important thing is that this operation must always be planned. But sometime on the operation table, when we decide that we have to do hysterectomy, so without delay, decision making must be very fast. And in the meantime, their counseling and everything, the hysterectomy must be done very quick and very planned way. Thank you. Thank you, Rita Di.
Thank you for this great lecture, Rita Di. And now I request the chairpersons to please come to give the memento to both the speakers. Dr. Amita, please give to Dr. Rita Sinha. And to Dr. Abha Rani Sinha. Over to Dr. Shraddha for the next session.
Thank you, Newton ma'am. So our next topic is a session from UNICEF, New Approaches for Engaging Community and Community Support to Ensure Optimal Health Behavior for Maternal and Newborn Care. To convene, we have the chairperson, Dr. Ranu Sinha ma'am and Dr. Ismat Khanam ma'am. Dr. Ranu Sinha ma'am is consultant obstetrician and gynecologist at PMCH Patna. She is nodal officer for PPIOCT, nodal officer Pradhan Mantri Surakshit Matritva, HIV and AIDS, master trainer of IPAS. Madam is chairperson Family Welfare Committee POX 2022-24 and national member of MTP Committee POX 2022 and 22 to 25. Our next chairperson is Dr. Ismat Khanam ma'am. Ma'am is a retired professor from ESIC Beta. Ma'am, please carry the session forward.
Thank you, Shraddha. Our next session is by UNICEF, and as said by Shraddha, it is new approaches for engaging community and support system to ensure optimal health behavior for maternal and newborn care. And our speaker is Dr. S. Siddharth Sankar Reddy. He is MBBS MD in Community Medicine, Health Specialist, UNICEF, Bihar Field Office. He is also graduated from University of Melbourne on Health System Strengthening. Please, sir, please come and deliver your lecture.
Respected chairpersons, all the dignitaries, and also my seniors, colleagues and friends. I would like to thank Patna Parb and the organizers for inviting UNICEF to present on community health aspect of the perinatology. And also I would like to wish you on the occasion of World Daughters Day to all the mothers and daughters present in the hall. So thank you very much for inviting me. So actually just Abha Sinha madam was presenting about the clinical and diagnostic aspect of antenatal care, but I will just present the reverse part of the antenatal care, that is the community part and also the social part of the antenatal care. Actually what is happening in the society and how actually government of Bihar is leading to improve the community health, especially for mothers and newborns at the community, and actually how that your support is very much essential to improve the community aspects of the essential care of per mother and also newborn. So before going to the presentation, actually just I want to show you the current maternal mortality ratio of India and also Bihar. You can see that the trend is very much decreasing since last 10-12 years, and now we are at a level of less than 100 at the national level, but at Bihar actually we are having around 118 per 1 lakh live births, and our target is to achieve around 70, less than 70 of maternal mortality ratio by 2030 as per the Sustainability Development Goals. And if you see that the trend and the rate of reduction is very much actually expectable, and also within the next 4-5 years we can achieve the target of 70. But actually you don't forget that achieving the last mile is very difficult. So we need to be work both at the clinical level also at the community level to achieve the maternal mortality rate of less than 70. One positive thing is that actually around 8 states in India, they have already achieved this target of less than 70, and one of our neighbor state, that is Jharkhand, also achieved the target of less than 70, that is at 56. So Bihar is like Jharkhand, their political, geographical, socio-economic condition is similar to Bihar. So we also hope that within next 5-6 years, we can also achieve the targets of 70. Similarly, this is the child health scenario of Bihar, but if you go to the neonatal part, then we have the neonatal mortality rate at around 21 per 1,000 live births, which is around 1 point higher than the national average. But the challenge is that the rate of reduction of neonatal mortality is not as per the expected target that has to be achieved. The Indian Newborn Action Plan of less than 10 or single digit of neonatal mortality by 2030. So current reduction of rate is around 4.08 in India, in Bihar, and 0.06 in India. But actually we need to accelerate this rate of reduction to achieve the targets by 2030 as per the SDG standards and also as per the Indian Newborn Action Plan. So actually where we need to invest. So generally we focus around the middle 2 parts of the this life cycle approach. We actually focus on the skilled care during birth at health facilities, and also we focus at the care of small and sick newborns at the health facility. Actually we focus on these 2 parts where actually we have the impact of reduction of neonatal and maternal mortality reduction. But actually we forget about the first part, that preconception and antenatal care, where actually around 23% of maternal mortality is contributed and around 10% of neonatal mortality is contributed. Similarly, the upper part, the community part, actually there also if you focus immediately after delivery to both mother and newborn, then we can also reduce around 31% of maternal mortality rate and also around 30% of the neonatal mortality rate. That means if we will focus on the community part, then we can also address around 50% of the maternal newborn deaths at the community by providing just simple follow-up cares and also early identifying of danger signs and referring them to the health facilities. So for this, government of India has launched a program called VHSND, Village Health, Sanitation and Nutrition Day. In Bihar, it is called as Arogya Divas, that has been launched since 2007. It is a multi-sectoral convergent program to improve health, early childhood development, nutrition and sanitation aspect of both mother and newborn and child. But unfortunately, if you go to the data one by one, so we will see that what is happening till that. So what are the components that has been rendered to the mothers, newborns and children and adolescents of the community? That is actually health. We are providing reproductive health, maternal, newborn and child health services, also including adolescent health and immunization services. Similarly, communicable and non-communicable diseases also services we also provide. For nutrition, we are providing growth monitoring, breastfeeding, complementary feeding, maternal nutrition, micronutrient and dietary supplies to mothers and children. And for early childhood development, age-appropriate play and communication for child's development and learning, we are promoting. Similarly, sanitation also, we are promoting hand hygiene, use of safe drinking water, construction of toilets and use of toilets, that we are promoting. So to implement this program, actually we have a lot of cadres at the community that I will be say, but what are the actually targets or services we are investing through this BHSND program? That is 100% registration of pregnant women in the first trimester itself. Then quality ANC services that includes at least 4 ANC by a qualified skilled birth attendants or service medical officer or doctor. Similarly, also postnatal care to all the deliveries. Then 100% immunization both to mother and newborn and also the children. Then diagnosis of child and maternal danger signs and referral to them, and also management of small illnesses at the community. Then nutrition management and 100% identification of malnourished children, treatment, counseling and referral to nutritional rehabilitation centers that has been established at the district level, medical college level and also sub-district level. Similarly, 100% identification of eligible couples and also providing family planning services. Also, it includes adults and health services, counseling and distribution of drugs to all category of beneficiaries. So here the target beneficiaries are all eligible couples, means those are married and currently not practicing any family planning services. Then pregnant women, 0 to 5 year children and their mothers, lactating mothers and also adolescents. So there are a lot of cadres that we already know. That one is the ANM. Actually, ANM is the we have around health sub center at around 10,000 population. That includes around 6 to 8 villages for the sub center area, where we have posted 2 ANMs, and we have also identified the work distribution of the each ANMs at the community, what they will be do for maternal, newborn, child health and adolescent, and also nutritional aspect of the programming. Similarly, we have ASHA workers, that is accredited social health activists. These are posted around 1,000 population in each village level. It is co-terms to the Anganwadi centers of our ICDS program. So here ASHA workers' main role is to mobilize all the mothers and beneficiaries to Anganwadi center, that is the BHSG session side, and also mobilize to the health facility for institutional delivery and to avail quality antenatal care services and also high risk services for mother and newborn. Similarly, we have also Anganwadi Sevikas and Anganwadi workers. They are not only focusing on the non-formal education or nutrition, they are also accountable for providing basic essential health services at the community and also mobilizing the community. Including Jibika, you know that the State Ruralhood Livelihood Mission, that actually they have a mandate to provide all the social services to the community, and the SRLM or Jibika is led by mostly women of Bihar, and it is a highly successful program of the government of Bihar and the Chief Minister's flagship program. So Jibika also, actually we are engaging them to provide all the basic and essential services at the community and also mobilize the beneficiaries to the health facilities and also to the BHND session site. Panchayat Raj Department, the elected peoples, actually they are actually the accountable person, and they are actually the persons who actually should take care of their public or their community. So we are also engaging them through this BHSND program to ensure all the BHSND services. So this program started in 2007. And if I will say that 2020, what is the progress of this program? No doubt a lot of improvement has been made, But still there are a lot of gaps are there, lot of challenges are there. If you see that mother had antenatal checkup in the first trimester, in 2020 it is only 52.9%. That means another half of the mothers we are missing to provide 4 antenatal services. Then mother early registration. Then mothers who had at least 4 antenatal visits, that only 25% of mothers are getting at least 4 antenatal visits. That means 75% mothers are missing these 4 visits. Institutional delivery, we are doing very good in terms of institutional delivery, both at private and public health facility. It is around 76%. Public health facility contributing around 56%, and the rest by your private health facilities. Then home delivery also, we are actually by the home delivery around 23.8% is happening in Bihar at the current date. So this is also not a good sign symptom of getting a safe mother and safe baby in future. Then out-of-pocket expenditure, this is actually very concerning because Bihar actually around more than 86% are living in the rural area, and their monthly income is less than actually 10,000. Around 70-80% people are home income is less than around 10,000. So, but in spite of all these, actually they are paying high for simple delivery. They are paying around 2,300 per person for delivery at the rural area. So actually, Government of India to curtail all these expenditures, hardship, financial challenges. Government of India is already launched a lot of programs like Lakshya program, like Suman program for zero financial hardship. Many programs they are running. So I think those people, those are non-affordable to go for private health facility, they should be directed to the public health facilities through the community support and also through your support. Cesarean section, that is very much under control in Bihar, not like the states like Hyderabad or Hyderabad or Maharashtra or Karnataka. But if you see the cesarean section at the private health facilities, as per 2020 data, around 40% of the deliveries that is happening at the private health facility, it is simple by cesarean section. That is also not a good sign for the future mothers and babies in terms of financial hardship and also survival. So the major challenges gaps we observed that actually there are 3 major challenges. One is gaps, that is supply side gaps, mostly due to inadequate healthcare providers, inadequate skilled healthcare providers, poor supplies of logistics required for the BHND session site. And for demand side, actually there are services are available at the community, but people are unaware about these services, and because of the local taboos, beliefs and cultural social norms, they are also not availing the services. Similarly, enabling environment, that we are providing health and wellness BHND services at the community, but unfortunately that site where we are providing the BHND session site, this is not adequate in terms of infrastructure, this is not adequate in terms of maintaining privacy, not adequate maintaining, providing services for toilet and hand washing, sanitation. So that's why there are a lot of challenge also that is coming. So to avoid, to overcome all these, Government of Bihar actually started one new program, that is a model special BHSND since 2023 January, and that initially piloted in 4 districts. One is Bhagalpur, second is Punya, third is Shekhpura district, and few are in the urban areas. So these 3 districts and urban areas, we started this program and successfully implemented, and we found that this modus of operandi was to address all these type of gaps, that community gaps, that means the supply side gaps, the demand side gaps, and also the environmental side, enabling environment gaps that we also provided. So with all these gaps, we addressed in the modus of operandi of BHSND special pilot, and also we built a strong monitoring mechanism, monitoring review mechanism to ensure quality of the RIH BHSND services. So we daily regularly reviewed the BHSND services at the health and wellness center, at the PSC level, and also at the block level monthly, and also at the district level and state level. So we also engaged the health department, ICDS department and PhD department to address all these gaps. So gradually now we are moving to a better version of the BHND session site at the community through involvement of all these sectors. And also Government of Bihar actually they also ensure that all the gaps in terms of ANM or ASA or Anganwadi worker, whatever there, they actually already place them in the BHND session side or sub-center level, and now we are actually 100% saturated with all the frontline workers that is needed to deliver the healthcare services at the community. So one special actually gap assessment was done by the Department of Health to assure that the maternal health supplies and logistics and services, ICDS supplies especially for children, for immunization supplies, green channel supplies, IC and IPC activities to mobilize the beneficiaries, and also family planning and wash related supplies, water sanitation related supplies, and medicines that are required. That a special gap assessment was conducted to address all these gaps, and these are actually the observations of the gap assessment that we did around the month of May 2023, and based upon these gaps, actually that Chief Secretary of Bihar, he immediately called a meeting with all the departments, and he directed all the departments to address all the gaps related to logistic, human resources, and that were immediately addressed. So one major challenge was how to address the demand side gaps. Demand side gaps, that means how to mobilize the beneficiaries. We actually piloted a quality improvement initiative in social behavior change, that in Punya district in January 2023, majorly that covering the period of from antenatal, the day of conception to first 28 days of life, that is 300 days of the period of the life of both for mother and the newborn. And the background was, it was in continuous with the Tarang module of Government of India. UNICEF actually developed a social behavior change module with focus on quality improvement in the community. So we created around 50 people of resource persons at the district level, and we trained them, and we trained also all the Anganwadi workers, ANMs and ASAs, initially in 8 gram panchayats, then we piloted in the 8 gram panchayats successfully, then we scaled across the district. Similarly, we also had a continued monitoring and mentoring system at the state and district level for this pilot project. Initially, we started in Kasba block of Punya, then it was rolled out in the whole district of Punya. So the 3 key mantras we followed that doing the same things differently rather than doing different things, that is doing a lot of things or additional things. Sustainability, no added resource. We didn't put any extra human resources or any additional persons or logistics. We actually used the existing resources and we actually fixed their responsibilities. So system strengthening approach, actually we used all the systems available resources, systems available guidelines, policies to implement this project. So let's come what happened. So objective of the QI quality improvement for SBC, to increase demand for and equitable access to maternal newborn healthcare services for mothers and newborns. This was the key objective of the initiative. To increase access to and demand for quality counseling services at the community level. To increase adoption and practice of preventive and protective behavior such as breastfeeding, immunization, maternal nutrition, regular ANC, family planning and institutional delivery. To increase male involvement, because we observed that hardly there is any male participation for any ANC services or immunization services. Even if mother is going for institutional delivery, hardly we see that any male is accompanying the mother for institutional delivery. So we also ensured that male participation should be there to take the decision of the male to support her wife or her daughter. To bridge the divide between the frontline workers and also community, the community members. So to address the gaps that actually that is happening in the community level, that either the frontline workers are not accepted or the community people, they are actually unaware. So to break that divide, we also engage both community and also the frontline workers. The socio-ecological model, to change the behavior, actually we target the individual human person, means individual mother or their family members that we targeted. For social change, actually we targeted the community level people and the institutional level people like the nearby medical colleges or institutions, nursing colleges or schools. So in enabling environment, we worked on the policy level and also at the system level to improve the programming. So this is just in the Hindi. So we actually worked at the community individual level, person level, then family level, then community level, then institution level, then the system level to improve the scenario. So the strategy we followed, that is advocacy at the highest level, including the top level bureaucrats and also the Department of Health, ICDS, PhD, and also at the district level, the district magistrate and community level, and including the PRIs. Then system strengthening approach we followed, that we engaged actually all the resources that are available through the system only used for this activity, intervention. Then partnership, we also partnered with the different line departments and also the Panchayat Raj institutions for this program. Then community mobilization, we engaged the community frontline workers to mobilize. ASA, Anganwadi worker, Jibika for mobilizing the beneficiaries. Then tapping the conventional and unconventional networks, like the influencers, like the faith-based leaders also, we engaged them for mobilizing and also motivating the community. Then converse between department also we followed, then build the social capita. Whatever the social capita means, the social structures are there at the community level, like SSG, GBK, we tried to engage them, leverage them. Similarly, we also try to counsel each and everyone through IPC by themselves, through the committee only. So this QI model actually followed 4 steps. Initial step, identifying the problem through the community by forming a group of mothers, and we engaged them to identify their problems. Then the next step, we actually engaged them for analyzing the services available and the quality of services available. In the third step, we also engaged them to develop their own action plan, and also that, testing that action plan, implementing and testing the action plan. And the fourth stage, whichever indicator or whichever activity or intervention that remained successful, we continued, and which were actually challenging, we tried to modify them or to rectify them. So actually in 2013, we had a state quality conclave under the chairmanship of Health Department, Secretary of Health, and also SCS Health. And this model actually received the best quality improvement initiative in the state, not only by the Department of Health, but actually national experts from NSSRC, from ASCI Hyderabad, they were also chose this as the best model for community intervention, for quality improvement. So now, how actually FOXY or ISOPARB or POX or BOX can support in this initiative? So while government has a sharp focus on improving the quality of health services, they are incomplete without the demand generation from community. So the community demand generation is the most important aspect. So already the frontline workers or the social capital that is there, they are working on this. But I would request you, whenever any person or any mother is coming to you, if he sees financially well enough or not, so if they can attend your hospital for delivery, that is okay. If they are unable to attend your hospitals, please guide them to go to the public health facility, where actually we are providing all services free of cost, including cesarean section. So this actually is the based upon the basis of the social ecology model. Try to involve the family and gatekeepers while counseling a client. The decision makers at family level need to be involved, including husbands, in maternal and newborn care. So actually male participation is also very much essential. Please continue the sympathy and empathy you are providing to all the mothers and newborns at your clinics and your facilities. That should be continued. Let us you should be the change maker for the maternal and newborn health scenario of the state, because the last mile, achieving the last mile is very challenging. So if you want to actually achieve, if you want to showcase your state to achieve the SDG targets by 2030 or the Indian Newborn Action Plan targets by 2030, so then actually we have to work with collaboratively with the health department, with all the development partners, and also your support is very much essential to improve the overall maternal and newborn, especially the perinatal health scenario of the state. Thank you very much for the patience listening.
Thank you, Dr. Reddy, for your very elaborate talk on this topic of the new approaches of managing the newborn care behavior of the maternal and newborn behavior care. So this main aim is to reduce maternal and newborn perinatal mortality, which is mostly the preventable cause, which can be reduced not only by the health workers, but community motivation, mobilization is very important in this, because so many facilities government is giving, but they are not coming for this, the community. So it is very important, and it is very good that government is taking interest in mobilizing and mobilizing by health workers, ASHA, Jivika, they are doing this with collaboration of health workers. Very important is not only during pregnancy, but prenatal counseling and health of adolescent girl from the very beginning, so that the risk factors can be identified.
Yes, ma'am. Actually, that already I mentioned that BHSND, that adolescent health is also an integral part of this BHSND program. And another thing, actually, I intentionally escaped, that is stillbirth. Actually, stillbirth is also a major contribution of perinatal mortality. So I intentionally avoided this because of we don't have any data, and whatever data we are having at the health facility level, actually that is false data. In terms of stillbirth, mostly we actually report them as a neonatal mortality, or most of the neonatal mortalities are reported as a stillbirth, immediate neonatal mortality. That's why I have intentionally escaped this information.
Thank you, sir.
For your excellent talk. Now may I request the chairpersons to kindly facilitate the speaker.
Since we are running short of time, may I request the next chairpersons to kindly come on dais. I request Dr. Kumkum Sinha ma'am, past President POX, a very dynamic personality. Ma'am, please. Dr. Shravan Kumar sir, who is popularly known as the father of neonatology of Bihar. Sir, we are pleased to have you here. I request Kalpana Singh ma'am, Professor and Head Department of Reproductive Medicine, a very enthusiastic teacher. Ma'am, please. This session is on the topic genetic screening on newborn by Dr. Mayank sir. I request the chairpersons to kindly introduce the speaker. Hello. Hello. Yes. Good afternoon to all. And this post-lunch session, we are having a very important session on screening of neonates, and that also for genetic diseases. At the onset, we would like to thank the organizers for giving us this opportunity to chair this important session. All of us together, we thank the organizers, especially Dr. Rita Sinha and Dr. Zareen Rahman. Now, to speak on this important subject, we have the esteemed speaker, Dr. Mayank Nilay. To introduce him, Dr. Mayank Nilay, his field of work is medical genetics, the new subject of today, and there were so many research is going on this subject. His MD Pediatrics and MDM Medical Genetics. His affiliations are Senior Consultant Genomics at Agilus Diagnostic Limited, Visiting Consultant Clinical Genetics at Sant Paramanand Hospital, Delhi, Ex-Assistant Professor, Department of Medical Genetics, PG Child Health, Noida, Ex-Assistant Professor, SGPG IMS, Lucknow, Senior Resident, MAMC LNH, New Delhi, Registrar Pediatrics, Cloud9 Hospital, Bangalore, Editor Board Member at SVOA Pediatrics of London, UK. And his fields of interest are many. He has been actively involved in the management of children with spinal muscular atrophy, genetic hematological disorders. And his other interests include lysosomal storage disorders, dysmorphology, inborn errors of metabolism, neurogenetic disorders, oncogenetics, next generation sequencing, and fetal medicine. He has 15 research papers to his name in both national and international journals. And I now over to the other chairpersons to have their comments.
Thank you. Thank you for giving the honor. Yes, this genetic screening is very important. I should say we were diagnosing the disease after the, it is not good. Now, if at birth, most of the baby having genetic, they had no any symptoms. And after some times, if sudden death or something bad happens, it is a very bad times, and parents will be furious. So it is better to diagnose. If you cannot diagnose, but you can screen. If you are screening all the baby, you are safe. So the genetic screening is not a diagnosis. You can screen whether, even if on screening you are getting some disease of hypothyroidism or genetic congenital adrenal hyperplasia or any genetic disorder. So it is not confirmed. You have to do another test. So genetic screening is must for every baby, even if baby is all right.
I invite you to speak on genetic screening for the newborn, because you already everything has been done in.
At the outset, I would like to thank the organizers of Patna Parb chapter. And I feel this, for me, this is a privilege because when I entered my third semester in MBBS in Bhagalpur, Dr. Himali ma'am was their faculty. And then in my MBBS external obs-gynae exam, Abharani Sinha ma'am was the external. So I'm feeling very nostalgic and emotional at the moment. This is my first talk at Bihar in any conference. Why I have kept this slide as the first slide? I think this is the era of reproductive genomics, and what I feel as a geneticist, obstetrics is the most important branch which has a greater role in genetics, and being obstetrician, you all should be aware about the various genetic testing options. Why? Because you deal with a couple. Apart from that, you are also involved in that perinatology part, and also some way you are also involved with the newborn. As rightly told by respected Dr. Shavan sir, newborn screening is an integral part. Now you can see the domain, whether it is a carrier testing, whether you are going for a pre-implantation testing or an NIPT, all these places there is a role of genetics. Yeah, now I have kept these few photographs of children who were referred to me in Noida, and you will be interested to know all these children were referred from Bihar. इन बच्चों को रेफर किया गया था. कुछ बच्चे थे क्वेरी MPS, क्वेरी डाउन सिंड्रोम करके रेफर्ड थे. I think residents are also there, obstetric residents are also there, and most probably देख के क्या लग रहा है, एक कोर्स फेशियल फीचर लग रहा है हमें, ठीक है, but sadly 3 children of these were having hypothyroidism. And why I feel this is a crime? Because this child, he was around 7 to 8 years old. He was never given the option of a thyroid test, and he was given ATT for 9 months कि abdominal tuberculosis है. ये 18 months वाला kid भी था वैसे ही, and this second child. Of course, this was mucolipidosis and this was achondroplasia. Now, why this is important? Because thyroxine is a very important hormone, and it is essential for the early brain development. So if any child, any newborn is deprived of thyroxine, obviously it is going to have an immense impact on his or her life. He is going to suffer an irreversible damage and severe intellectual disability. And as the pediatricians know, if we start giving thyroxine at a proper age, the intellect will be normal and the development of the child will be almost normal. But depriving the child with a thyroid screening test led to a child having severe intellectual disability till 7 years of age. Even when we started thyroxine for this third child, a little bit facial features improved, but of course intellect is not going to be like a normal child. So by these figures, I just want you all to sensitize and get sensitized why newborn screening is very important. Now, what is newborn screening? Screening basically for certain disorders for which certain treatment is easily available, and of course, the diagnostic test is also quite feasible. So NBS, as you all know, regarding the history, it all began in 1934 when Folling identified through a diaper test or something like a ferric chloride test for a test for phenylketonuria. Many children were having intellectual disability, and he found that test. Later on in 1968 in New York, when Dr. Guthrie was there, on which the name of the test has come, who started that bacterial inhibition test. What was good about this test was that a lot of samples can be tested at one time. Using this technique, New York government, they started universal screening for PKU for all children in 1970. So it's almost 6 decades back when they started for PKU. But where are we as India? I'll also talk about the burden of NBS for our country and what we need to do. Criteria was also given by Wilson and Jungner in 1968, and this is the basis of any newborn screening anywhere in the world. Basically, the condition, we cannot screen for everything. There are around 8,000 to 10,000 genetic disorders. But is it feasible to screen for all? No, it is not feasible, especially for a country like India, where we have cost constraints and other issues. So first, we need to recognize the prevalence or the incidence of the disease. If certain disease, the prevalence is very high, of course, it is going to be an important health problem. Apart from that, do we have facilities for diagnosis and treatment? For example, hypothyroidism. The treatment is very cheap. Just thyroxine is very cheap drug. Accepted treatment is there, and again, and if there is any advantage to diagnose in an early stage, many inborn errors of metabolism, such children are asymptomatic in the neonatal period. They may develop the symptoms in latter part of the life. So if we diagnose them early through a newborn screening or extended newborn screening, we can give them an adequate treatment or the dietary modification since their birth. So of course, these are the things. Basically, in this slide, I have shown you an NBS system. Many times it comes to the mind of obstetrician कि भाई हम डिलीवरी तो करा ही रहे हैं, कितना लोड ले, अभी फिर NBS का भी लोड हम ही ले लें, उसके लिए अलग से आदमी रखना होगा, अलग से स्टाफ रखना होगा. It's not like that. It's a very easy test which we all can do. The labs can provide you various filter papers. You just need to use little bit of hill prick, which I'll show in further slides. Just putting on the filter paper, you just get that filter paper drying, and then it is referred to a field worker to the lab. In your case, as in Bihar, universal newborn screening is not there. Some states like Delhi, Chandigarh, Goa, Kerala, they have accepted universal newborn screening, at least for the common disorders. Till then, what you can do as an obstetrician, you can sensitize the couples who are visiting you regarding the serious impact of such illness. So what are the components of NBS? As already told, education. Creating awareness is very important, because still I feel even many medical professionals, they may not have an idea कि भाई क्या कराना है NBS से, क्या फायदा होगा, 1000 बच्चों में एक बच्चों को तो help होगा, but that single child is very important for his or her family. So we shouldn't ignore them, and we shouldn't miss something which is being done by other parts of the country. So screening is of course very important. An early follow-up. Once you diagnose any child to have a suspected disorder, you should keep following up the child. You should go for certain confirmatory tests. Diagnosis should be confirmed by a genetic testing. And of course, management is long-term, because most of these children, they require certain supplements and therapies which continues lifelong. So what are the benefits of NBS? Identification of the children, early intervention, of course, reducing the morbidity and mortality, and family planning as well. Because if a family is having a child with congenital adrenal hyperplasia, they may want कि मैम मुझे अगला बच्चा normal चाहिए. So here comes the role of an obstetrician. You can offer them a genetic test, confirm the diagnosis, and the next pregnancy you can give them an option of prenatal testing. Now, any test, any procedure has certain risks in medical science. So what are the risks of newborn screening? Parental anxiety, because there are always certain chances of getting a false positive result, especially in premature children. Sometimes in an NICU when the child is having sepsis or certain liver dysfunction, in that case the levels may be up and down. Then of course false negatives also do come. And the other risk is the right not to know. Many families may not want to know, or they may go into certain anxiety. Certain unanticipated outcomes may come. For example, the child is perfectly normal at the birth, and you are telling कि भाई बच्चे को biotinidase deficiency आई है, आपके report में आया है. तो family can be taken aback कि मैम आप क्या कह रही हो, बच्चा तो मेरा normal है. Because you know biotinidase deficiency, it can present later on in the infancy with seizure and other changes. So child can be normal at the time of birth. So counseling, even pre-test and post-test counseling is very important. Now timing of testing, this is very important for all of you. क्या टाइम है, कब करना है, अभी day 1 पे कर दे, day 2 पे कर दे. Various international guidelines are there, and best thing is to do that after generally around 48 to 72 hours for a full term baby. Now why that is, why कि हम second day पे ही करें, हम first day पे क्यों ना कर लें? Because most of these enzymatic disorders or inborn errors of metabolism, they will show their real picture when something goes in the mouth of the baby. When the baby starts feeding, milk गया, enzyme ने act नहीं किया, toxic product accumulate किया, then features आ सकते हैं. Apart from that, delivery is in itself a topsy-turvy event. So many biochemistry is not that settled for child, and gradually around 48 to 72 hours, many enzyme levels, they settle to a normal level. And of course, generally, if there is any emergency, you are testing the child within 1 day, better to repeat the test after a certain period of time. Certain special considerations, for example, a preterm delivery. In that case, you should collect it after at least 5 to 7 days. And if the child is in NICU on total parental nutrition, again it will be elevated. And of course, transfusion. Sometimes a baby may born who is having anemia. You may transfuse the baby. And suppose you are not able to do a newborn screening. The family will ask, ma'am, fir hum kam karaye? Ideally, at least 2 months of gap should be there if the baby has been transfused at the time of birth. Now, regarding the Hill test, as you can see, I've marked these 2 areas. The best thing is to take it from the medial part or the lateral part. Generally, the labs will provide you the DBS kit and sterile stillates. Your technician can clean the area and they can do the Hill prick and they can collect the drop of bloods on the provided DBS card. So it's quite easy to do with practice, and it is not necessary कि circle पूरा ही भरा हो. At least 2/3 of circle अगर भरा है, तो it's well and good. Don't do repeated dropping of the blood because it may lead to caking and overlapping. फिर वो results अच्छे नहीं आएंगे. And after doing this blood collection procedure, let it dry for 4 hours, then pack it and send to the lab. Or better, if you are doing it with any lab, they may assist you in all these activities. Initially, basic newborn screening में क्या है? Generally, 5 conditions are advocated even by the National Neonatology Forum, like congenital hypothyroidism, CAH, G6PD, galactosemia, biotinidase deficiency, and cystic fibrosis is the 6th one. Why I have kept this? Because most of the places are adopting this. Even I started this at PGICH Noida. Why? Because there are studies from India, like from Gangaram Hospital, Delhi, which have shown the carrier status of cystic fibrosis is 4.5%. So it is very high. Or what happens in a cystic fibrosis? Generally, it may affect the lung and the liver of the child. So it can be something of a multi-system involvement. So generally, many labs are offering at least basic 5 and basic 6. Of course, for us, cost is a big constraint. So you can offer कि ठीक है at least basic 5 or 6 disorders करा लो because इनका incidence India में काफ़ी ज़्यादा है and treatment is available. For CAH, we can start on fludrocortisone. G6PD, why it is important? Because we get to know that there are certain drugs which may create a hemolysis. Then there are certain studies from India which have clearly shown that certain other inborn errors of metabolism, especially amino acid and organic acid metabolism, they are quite common and they also need to be screened. Now, what is an expanded newborn screening? Expanded newborn screening has been coming up for last few years with various researches. It includes various other inborn errors of metabolism. It also includes the 3 hemoglobinopathies. Recently, even Government of India has adopted the screening for sickle cell disorder. And apart from that, it also includes a screening for hearing loss by otoacoustic emission, which you should encourage to the newborn. Apart from that, there can be screening for critical cardiac illnesses. And this is a very easy thing which can be done by a pulse oximeter at your clinic only. Eye screening should also be advocated. Now, in this slide, I have just shown various inborn errors of metabolism which can be detected by newborn screening. Now, what to do when a screen comes positive? The family may ask you, कि मैम आपने NBS कराया, बच्चे का screen positive है, next step क्या है? We need to confirm it by plasma amino acid analysis and urinary GCMS analysis. And of course, take the help of your pediatrician. In this, I have just shown the punching and the machine which was there. Various techniques are there. We don't need to go into detail. Immunoassays generally, especially for thyroid. And then what is a tandem mass spectrometry? This came in 1990, especially for the analytes like acyl carnitine and amino acid profile. It is basically MS. There are 2 analyzers, mass analyzer 1 and 2. They separate the molecules on the basis of mass by charge ratio. Now, like fatty acid oxidation disorder, the newborn may present with a hypoglycemia, coma. With amino acid disorders, they may have acidosis, coma, something like that. Urea cycle defects, all these are very common. And if diagnosed early, treatment can be started and the child may have a normal life. Now, burden of genetic defects in India, you'll be surprised to know that around 10 to 15% of pediatric emergency admissions have some genetic etiology. Many children are still coming up in India with various disorders like thalassemia major. Despite having that Jai Vigyan program of ICMR and thalassemia screening, still we are seeing kids with thalassemia. So we need to do something. We need to make ourselves aware and we should encourage the couple to go for all these screenings. Need of NBS program is very important for India because WHO has given a guideline. If your infant mortality rate is coming below 50, you should start thinking for genetic disorders. And the infant mortality rate of India is around 26 per 1,000 live birth in 2022. So we should encourage for that to the couples. And of course, hearing loss, congenital hyperthyroidism, adrenal hyperplasia, all these have been adopted. Various categories have been defined by National Neonatology Forum. Category A, at least we should offer to all the couples, irrespective of the economic background, because these are very cheap. At least for hypothyroidism, hearing assessment, CA, G6PD, and in a parts of a northern part of India, especially Bihar, Jharkhand, we should also encourage them for sickle cell screening as well. Category B, it includes those families who may have a consanguinity or any history of previous child with intellectual disability, seizures, or any bad obstetric history. We should offer them certain extended screening, which should include conditions like PKU, homocystinuria, galactosemia, cystic fibrosis, and other conditions. Now, what is carrier category C? This is for other metabolic disorders. Of course, this test will be little bit costly as compared to the basic 5. This you can offer to the families who can afford. And it is also not that costly, something around 5,000, 7,000, something like that. Incidence of various studies in India, like our genetics group study was also from AIMS. It showed that hypothyroidism, the prevalence is as high as 1 in 1,000 children. So you can see how common all these disorders are. So what are the issues standing for us? Awareness, cost, advocacy of such NBS by doctors as well as the policy makers, and of course the political will is important. So what are the issues? Lack of awareness of inborn error of metabolism. Many times in NICU, the children are getting a diagnosis of birth asphyxia, sepsis, and we are not trying to find the root cause. As a geneticist, at present I feel even a child going into primary apnea or secondary apnea, there is some genetic predisposition which needs to be found out. Yeah, there are two models which can be done for a state like Bihar. One is a point of care model, and another is a central laboratory model. In point of care model, if we have certain issues, we can do a public-private partnership and we can start that thing. Apart from that, multiple central laboratories can be started and the testing can be done, which has already been done in Lucknow and Delhi as a part of NEEV program. And of course, as told by the previous speaker, we can involve ASHA workers to encourage the family, and at least if a child is getting screen positive, they can bring the child for regular follow-up. Now lastly, I'll just show a case scenario. This was a child who was referred to me in Delhi. This was a child of spastic cerebral palsy. As a pediatrician, हम लोग history लेते हो बार-बार कहते हैं अच्छा देर से रोया था, तो बहुत बार ऐसे leading question, हाँ सर देर से रोया था. There was no history of any documentation, but delayed cry करके इसको tag कर दिया. ये spastic CP है. बच्चे को seizures हो रहे थे, he was very hyperactive, something like autism spectrum disorder. They came to me. I took the family history. There was history of consanguinity. There was microcephaly. It was -4 standard deviation. Apart from that, most of the examination was normal, apart from spasticity. Routine blood tests were normal. I reviewed the MRI brain. Thinning of corpus callosum was there. Again, there was none specific. Then I went for an extended newborn screening, which can be done any time at any age. Because I was suspecting there must be some neurometabolic disorder, and surprisingly, serine and glycine level were very low in this child. Now what to do next? I went for the exome sequencing test and we found that the child was having a defect of serine metabolism. तो अब एक दिल में सवाल आना चाहिए कि भाई आपने क्या ही कर दिया, जेनेटिक टेस्ट करा दी, मरीज के पैसे खर्च हो गए. But the good thing was that the treatment is very cheap. Most of the inborn errors of metabolism right now in India, very easily available treatments are there, whether there are drugs or whether there are modified protein-free formulas. I started the child on serine and glycine. Within 3 months of therapy, seizure have stopped, and I think I'm following up for last 1 year. Hyperactivity has also decreased, and the cost is only around 2,000 per month. उसका लिवेरा बंद हो गया, सारी चीज़ें बंद हो गई. So that is why here comes the role of a newborn screening. But sadly, the treatment started at 3 years of age. यही अगर जन्म के समय उसकी स्क्रीनिंग हो गई होती, जन्म से सेरीन ग्लाइसिन दिया होता, तो बच्चा ऑलमोस्ट नॉर्मल होता. There are a lot of conditions which mimic cerebral palsy, which we should keep in mind. So the take-home message is that catching something earlier is always better, and do follow babies who are screen positive, and it is a multidisciplinary effort. Obstetrician, primary care physician, pediatrician, they all need to be involved. And of course, I'll end with this: no scientific field has greater impact on genetics than obstetrics. Thank you.
Dr. Mayank, it was a very nice paper, and you had, this subject is so new, and then you have said in so much detail. And we also feel a little bit set back, like in Western countries, USA and all, this neonatal screening is compulsory. Yes. In all the states, they are having different, nearly 50 screenings are done in the newborn baby within 3 days to 1 week of birth. Yes, 1 day after breastfeeding and 3 days if after birth. But with having the second largest population in the world, our newborns are not being screened. It is so sad. You have said all these things that have been screened. Like, suppose we are not so aware and there's a genetic family history and a patient comes and delivers and then she goes back and then she comes back to you after 1 month. Will you screen again? Because that golden period has been lost and the baby is coming again after, say, about 1 month for something else, but the history is there. Would you like to do the screening again?
Yes, extended newborn screening, especially मैम TMS, GCMS, you can do at any age. अगर बच्चे का बचपन में भी नहीं हुआ है फिर भी हम स्क्रीन कर सकते हैं. And if there is certain history in previous pregnancy, for example, intellectual disability and other things, we need to examine the proband. हो सकता है उसको कोई क्रोमोसोमल डिसऑर्डर हो, मोनोजेनिक डिसऑर्डर हो, हर बार तो इनबॉर्न एरर ऑफ मेटाबॉलिज्म नहीं होगा. तो आई विल सजेस्ट always get examined the previous baby first by a geneticist or at least a neurologist so that you get a diagnosis. And of course NBS though we should propose to all the families. I do propose and many of them opt. It's not that very costly.
It was also written that you screen for the hearing loss.
Yes, ma'am.
And it is done in 1 day baby also.
NBS
And yes, but they also said, well, even if it is detected that the baby has hearing loss, you wait for 1 week because all the debris and all the liquor that has gone inside,
Yes,
that will dry up and then the picture might change.
Yes, ma'am.
So they are also giving hearing aid also at 1-year-old babies also.
मैम जनरली तो मिशन नीव प्रोग्राम है दिल्ली गवर्नमेंट का, एक दिन के बाद ऑटो एकाउस्टिक की मिशन करते हैं हम लोग और उस पर कोई फाइनल डिसीजन नहीं लेते हैं, फिर फॉलो अप करके वी डू बेरा और उसके बाद व्हेन वी कंफर्म की हियरिंग डेफिसिट है तो वी डू हेल्प देम विद द एड्स.
So thank you so much.
Thank you, ma'am.
I request Dr. Sonali to kindly take up the next session. I request the chairpersons for this session and our speaker, Dr. Mayank, to kindly come up on the dais for the distribution of the mementos. Dr. Sonali.
Thank you, Dr. Bhavna. Our next session is first trimester screening. I request Dr. Anjana ma'am and Dr. Pragya ma'am to please come to the stage. Dr. Anjana ma'am and Dr. Pragya ma'am, please. Dr. Anjana ma'am is Associate Professor, PMCH. Sorry ma'am. Good morning, madam. Dr. Anjana ma'am is professor in PMCH Patna. Madam is the national trainer of EMOT, RTI, STI, IPS. Very short of time. And I request Pragya ma'am also to please come. And Pragya ma'am is Secretary General ISOPARB. Madam is Chairperson Genetic and Fetal Medicine Committee FOXY. Madam is the Founder Secretary ISAR Bihar Chapter, Vice President Patna Ops and Gynae Society from 2021 to 22. Madam is Secretary Patna Ops and Gynae Society, Examiner MRCOG examination, FOXY Certified Colposcopy Training. Madam is the Organizing Secretary, FOXY LaborCon, Organizing Secretary, FOXY ISPAT, and all these things. Madam. Over to you, ma'am.
Now we are going to have a very important panel discussion on aneuploidy, diagnosis in first trimester of pregnancy, and for this we have got very brilliant panelists and calling them on stage, and Dr. Pragya Mishra Chaudhary and myself will moderate this session, and everything has been done by Pragya. I'm just standing here, and it's okay. She is a young, and she was also chairperson of fetal medicine. So all credit goes to her. So our experts are Dr. Alka Pandey and Dr. Vinita Singh. Hope they are there. No, they are not there. Okay, no worries. So our panelists, Dr. Sangam Jha, please come. Dr. Pooja Kumari, Dr. Shraddha Chakiyar, Dr. Swati, Dr. Vinita, Dr. Bhavna Tiwari, Dr. Kumari Mamta, and Dr. Ashita Srivastava. उधर हो जाएगा तो कोई दिक्कत नहीं है उधर नहीं हो जाएगा ओके ओके So why screening is very important in first trimester of pregnancy? Out of four per 1,000 pregnancies, they have chromosomal anomaly. And if screening is done, it increases up to 8 per 1,000. So, so anyone can answer, or from this side we can start. What do you think? What is a screening in a screening in pregnancy of any disease? Of any disease?
In a fetus before it is born, in a pregnant lady.
Anyone?
So it
Who
is
wants to add
actually
something to it?
estimating the risk of having an anomalous baby in a pregnant woman. Actually, and the criteria for screening a disease, that disease should be treatment should be available. At least it should be modify the disease condition. The screening test should be strong enough to have a strong detection rate with a minimum false positive rate.
Yes. So screening in pregnancy, surveying a population of women with markers and defined screening cutoff levels to identify those at a high risk for a particular disorder. Now, anyone who can say what should be the qualities of a screening test?
Ma'am, for a screening test to be good enough, first of all, it should be acceptable to the population to which you are targeting. It should be affordable. It should not be too costly because you have to give it to a large group of population, and it should have a very high sensitivity for the purpose. And then again, like Sangha ma'am said, that there should be some treatment available, and also it is a screening test, so there must be a valid diagnostic test for backup. Like if the screen positive comes, then there should be something to diagnose it. So these should be there.
So yes, Bhavna, I think you have covered all the points. Now, what are the factors that potentially affect the screening performance?
Anybody, just some practical.
Any screening test, to be qualified it as a screening test, it should have at least 70% sensitivity and not more than 5% false positive rate. And any screening test potentiality depends upon the prevalence of that disease in the general population which we are examining.
That is Ashita, right?
Yes.
Yeah. No, from practical point of view, like what would you tell the laboratory, some information which the lab needs so that, you know, the screening test can be as, I mean, the performance can be better of a screening test.
So, regarding especially first trimester screening or second trimester screening, they want to know what is the ethnic origin of that particular women we are screening
Very
for.
good.
What is the age, what is the body mass index of that particular women, smoking habit, etc. And what is the BMI of that woman.
Yeah, because many markers do, if they are affected by all these factors.
So most important is ascertaining the gestational age of the fetus, because most of the markers are dependent or are gestational age dependent. And then the other factors she has mentioned.
And
diabetes mellitus.
What does obesity do? It's, you know, if a woman is overweight, you need, the lab needs to know because of the effect of physiological dilution, and you can get a wrong report, isn't it?
Yes.
So there are some factors, you know, which are mentioned in the slide. Some more, because this is a very practical thing, you know. So it's all given in front of you. So what are the things you need to tell the lab?
One is the age, gestational age of the patient, weight, ethnicity, BMI, diabetic status, whether the conception is natural or IVF conception.
Yeah,
that is
We can tell the risk factors that are present in the woman and what we are looking for, so that the lab can be more focused and able to screen those diseases.
So, you know, when it comes to ethnicity, it's quite interesting that women of South Asian origin have a higher serum beta HCG and PAPE. So it's very important, and I mean, that is in comparison to Caucasian women. So that's why, we need to inform the lab about the ethnicity, okay, and the weight of the patient. And dating is very important because unless and until the dates are correct, one would go wrong with the screening totally. Okay. So, yeah. Yeah, okay.
So when we do a screening of aneuploidy screening, it can be assisted with many biomarkers, then the results are more sensitive. And the detection rate becomes high, yes. So that is nuchal translucency, and the markers are, the two markers?
PAP A and
HCG,
free
pregnancy
serum
associated.
beta HCG.
One at a time, one at a time.
PAP A and free serum beta HCG.
Okay.
And the duration of pregnancy should be at least?
11 to 13 weeks.
plus 6
Although
weeks.
it is said that if you do a PAP A at 9 weeks and then you do NT and SCG at 11 weeks, but it is not at all feasible to call the patient twice.
Yes.
So, and it should be cost effective for at least in our setting. So, yes,
Yeah,
you can read it out.
Yeah. I'll skip that. Okay. Now look at this. Even Foxy's guideline. Now, what I would like to ask you, that normally, I mean, when you do combined testing and say the result comes as high risk, so would you totally go for an invasive testing, or would you like to do something contingent upon that? So we will discuss in the cases. This is just an introduction. So I'll just quickly go through this. Now, Foxy recommendation also is that, if the risk is high, which is about greater than 1 in 100, then you could go for NIPT or chorion-villus sampling. If the risk is intermediate, which means between 101 to 999, then you can leave those women for quadruple marker screening. Okay. And if the risk is even less than that, which means less than 1 in 999, then these women can do nothing. Straight away they can go for for the level 2 scan. And I mean, this concept was initially propagated by Nicolaides, and but the newer one I will deal with when we are doing the cases. Okay. So now just very simple, these are some, not even cases, actually some case reports of patients. Now this patient who's 28 years old, right, and who has had 2 miscarriages, first trimester screen shows these are the results. Okay, PAP is very low, 0.1, serum beta HCG, the value is given, the uterine artery PI, because your sonologist has given the report. Now based on this biochemistry, as you can see that the risk of trisomy 18 and 13 are quite high. Okay, 1 in 10 and 1 in 116 respectively. Okay, now what next now? Here what I'm trying to highlight that the lab, has given the report just based on biochemical markers. So that's why, I started talking about combined testing. So who wants to answer? Sangam, yes.
Actually, only biomarker screening has a very low sensitivity. So we need to combine with the maternal age as well as
maternal
USG
age is
marker.
given because she's young, she's 28 years old.
But that has not been included in the calculation of, I think, risk calculation, because they have written the biochemical screening risk. So the combined risk has to be calculated, and as per the whatever risk comes out, then we should proceed with whether we can go for like an IPS, or if she falls in the higher risk group, we can go for invasive testing to confirm the diagnosis.
This is why I have put this
in this
thing
case,
up.
ma'am, it has...
One sec, why I have put this, because this is a common scenario. As so many even, reputed labs, if you just write double marker, they'll just give you the report of serum beta HCG and PAP. Yeah. Okay. And then, actually then this lab had to be contacted that, you know, the ultrasound report is in front of you, then, you know, you should be actually combining all that.
And there are certain softwares, ma'am, like Prisma software and other, which takes the maternal age, the NT calculation and all these biochemical tests, and based on that, the risk is evaluated. And if the risk comes such a high, like if it is less than 1 in 100, so those are high risk, and these women need to be further screened. And the screening we can start with NIPT. If it is, NIPT has a higher sensitivity, the detection rate is high. So if NIPT comes to be positive, then only we will go for the invasive test, because still it is a screening test.
I don't agree with this. I don't
Ma'am,
agree
I don't
with this.
agree.
The
I
patient
don't agree.
falls in a higher group, straightforward, we should go for confirmatory
Ma'am,
test,
once-
to offering a second screening test.
One
if
at
she
a time,
falls
but-
between
no,
the
now look at
intermediate
this,
group, it's about, we
Look
can...
at this slide now. As you can see, well, NIPT, okay, you know, I'm just highlighting. We'll go to NIPT. We have many NIPT stuff, you know. So combined screening, it has a detection rate of 87%, right? And just, you know, here the double marker is not mentioned because we ideally shouldn't be doing just that test, but people are writing for double marker. So the detection rate is much lower than combined screening, isn't it? So we should never, the message is that, you know, never just go for a combined, just write double marker test. If you're writing double marker, you have to write NT plus double marker, so that the lab also knows that, you know, they have to take all this in consideration. Yes, now someone was... yeah, sure.
Agreeing with Sangam ma'am, that because you have already got a high risk in one screening test, considering our population, especially we had certain talks also we heard that low resource setting, you are again giving NIPT, which is again the screening test. Already you have got a high risk, so offer her diagnostic test like CVS or amniocentesis depending upon her gestational age. That is my take, ma'am.
Yeah. Madam, just want to add.
Here the risk of T21 is very, very low, as you can see. And the 18 and 13.
No. Now what, one sec, now what, after the lab was contacted, then now they have reported with age, you know, as Sangam was pointing out. So age, biochemistry, nuchal translucency, and they have taken the secondary markers also like nasal bone, tricuspid flow, fetal heart rate. And now what's happened, you see that the risk of trisomy 18 and 13 is very low, isn't it? So based on that, one would actually would have gone for an invasive testing. So that's something for the audience to really know. Please don't write just double marker, because you can get terribly wrong reports with just double marker. Thank you. So now in this case, you know, the first slide showed that the PAP-A was very low. So now what can low PAP-A predict, and what would you do? Very crisp and very brief.
Ma'am, it predicts FGR. So these all pregnancies have to be like below 0.4, or for Indians at a 0.45 MOM. We have to take them as a high-risk pregnancy, and 26 weeks onwards, we have to go for a 4-weekly growth scan in them.
Along with growth scan, we should do the Doppler also 2-weekly. And before that, because PAP-A is on the lower side, we should add aspirin. And then definitely it should be treated as a high-risk pregnancy from 26 to 28 weeks. We should do the color Doppler every 2-weekly. If it comes normal.
So low PAP-A could, you know, could predict fetal growth restriction future
as
on
well
in the
as
pregnancy.
early miscarriages before 20 weeks, preterm delivery.
Yes,
so the
preterm labor and
pregnancy is
delivery.
at risk of adverse outcome, and we should be closely monitoring such pregnancy.
So now it's important, you know, for people sitting that, you know, just don't look at what the lab has given you, low risk, high risk. Look at the individual mom values also that they have given. Now, if PAP is low, it means that these women need more of screening and surveillance future on in pregnancy. And as Shraddha was saying that, you know, they would need fetal, regular growth scans and Dopplers in pregnancy, if we don't want mishaps. So it's very important, you know, to pay attention to these individual mom values also, not just what the lab is giving, low risk, high risk of, okay. So this was a paper which was on maternal markers as predictors of adverse pregnancy outcome. And so regular growth scans, we already said, to assess interval growth like a volume and Doppler in view of low PAPE. So anyway, this patient's final report, was actually, it was a low risk, as I showed you. Now, this another advantage, of doing screening now in early pregnancy. Dr. Anjana Sinha had said, why do you want to screen? So now this patient later on, because this happens, this is a very practical thing. At, at 17 weeks is slightly, early for a level 2 scan. But anyway, there was one minute echogenic foci in right ventricle and 2 minute echogenic foci in the left ventricle. Extended cardiac survey was also normal. So what next? Now, because of this, are you going to subject your patient to invasive testing? Because things have changed now. I mean, that's the whole value, of first trimester screening. I mean, early pregnancy screening. Sangam?
Actually, these are the soft markers that tells that patient can have a anomaly or any genetic disorders. So, but the single soft marker doesn't warrant a genetic testing. So, we should first do a detailed scanning to look for the another soft markers, and if it is only the single echogenic foci present,
No, it is single only, just one soft marker is there.
Detailed ultrasound is showing no another soft markers in the fetus, then we can just have a counseling to the patient and no further testing is required. But if
not only that, I mean, in the first trimester, here the good thing is that you have not missed out on first trimester screening. And first trimester screening was normal. It was a low risk.
So
actually, you can reassure.
And then again, there is no other soft marker apart from this echogenic foci. So we can counsel the patient that your pregnancy is going to be normal. You will have a normal delivery, so a normal baby. So we don't need any further investigation.
So based on just isolated soft markers, we should not be subjecting, because almost it is so common, to find a report like this.
The sensitivity of combined test is quite high compared to this isolated soft marker, which has a very low sensitivity. So if the combined test is normal, that means the risk of having any anomaly is quite low. And this single isolated soft marker has no significance.
That's why we should not miss that opportunity of first trimester screen. So if you have done, the obstetrician also gets, is quite, confident that, first trimester screen was normal. So many times, but, I've seen reports, from actual fetal medicine centers and all, where they noted down on the ultrasound from report that first trimester screen was normal. So patient, so nothing needed, like routine follow-up. So that's one thing which is, I wanted to highlight. Now, this case, yeah.
Now this case, a 30-year-old female gravid at 3, para 0 plus 0 plus 2 plus 0 has come for ANC at 8 weeks gestation. She gives history of 2 spontaneous abortion for gestational age 6 weeks each. What screening test should you be advised to the patient? Yeah, isse aage hum log chale. So, kya test, what will you tell her to? At 8 weeks, would you like to tell something?
No,
only 8 weeks.
Everything is normal.
Yes.
Here we won't talk about recurrent pregnancy loss, APLA and karyotyping and all.
No.
Yeah.
So here, the case is already she has 2 loss, but we will go for normal first trimester screening only.
And so we are going to do?
NT.
What age we want to do the NT?
12 weeks will be the most ideal. That time we can go for serum marker also, as well as NT scan.
So what is the cutoff of NT?
It is less than 99, 3.5 mm is the cutoff.
I think
see, one sec. Well, Mamta, here I would like to intervene. I think Pooja should comment actually on this. see, NT is also something, which has to be plotted on a centile chart. And our sonologists are not doing that. They are not even plotting, growth on a graph and, uterine PI. They should be doing all that. So it's all, gestational age dependent.
Yes.
However, if it is 3.5, which
For a,
means
for a CRL, needs to be from 45 to 84 millimeter, and the NTV needs to measure from the software we are using, that is developed by Dr. S. Suresh.
3.5 is actually
Is
at the
actually a higher
99th
one.
centile.
It is more than 95 percentile, ma'am.
99th.
Yes. Next investigation.
So Pooja, you want to tell, how, just quickly, some of the salient features of how one would measure the NT.
The we take a mid-sagittal section of the face. The fetal needs to be in a neutral position, and we magnify the image such that the fetal face and upper thorax occupies the maximum screen. And the landmarks are, we take 3 echogenic lines, that is the brainstem, cisterna magna, and IT, which is called the future fourth ventricle, and we measure the NT, which is behind the neck of the fetus. And the front landmarks are, we take 3 echogenic line, and one is the nasal tip, nasal skin, and the more echogenic part is the nasal bone. If nasal bone is present, so trisomy 21, 13, 18 is ruled out, and we take these markers.
So how many measurements do you take actually?
We take 3-4 measurements, and the more which is filling all the criteria, we record on the database, on our software.
What if
widest wala part?
What if you find a cord around the neck? Then how would you measure NT in those cases?
It occurs in 5% of cases. We take the 2 measurements, one is above and one is below, and take out the average of the 2.
Okay. So okay, so now what is the significance of increased nuchal translucency? Is it only aneuploidy, or is there some more significance to that? Who wants to answer this question?
It is
Bhavna. Okay.
Apart from the aneuploidies, it is also increased in cases of certain cardiac defects and congenital diaphragmatic hernia, also in cystic hygroma. So it's not only indicating about aneuploidies, it is associated with these also and several other genetic disorders also, ma'am. So it should be definitely done and screened out. Structural anomalies also. Yes.
Defects can be also diagnosed by measuring the NT.
So what next? What next? I mean, if you find increased NT, so what next? What would you do next? Dr. Vinita.
Yes, ma'am. So if there is a raised NT, we will go forward with the with the combined testing and look for the serum markers, because raised NT is most commonly associated with the aneuploidies to rule out the trisomies. And also we would also like to have a detailed structural look at the to rule out various structural anomalies which are usually associated with the raised NT. Even with the NT film that ma'am described, that the mid-sagittal section, you're looking at the face as well as the upper thorax. That itself, that image itself helps to rule out many of the anomalies, especially if there is an anencephaly or a holoprosencephaly, most of the or a dilated ventricle, or for that sake, if there is a complete spina bifida, that single image itself rules out many of the structural anomalies. Okay, so NT, with a raised NT, definitely we have to go forward with the combined testing.
No, karyotype, I'm asking, karyotype is normal here. That's why Dr. Anjana Sinha mentioned that everything is normal except for, the NT, which is, that's why I asked what next? Raised NT, you have ruled out aneuploidy.
This patient should be followed by
level 2 scan.
Early anatomy and fetal echo at 16 weeks. And we have to see the anatomy again for looking for a structure.
You can look at the audience and answer, then
Yes.
it will be better.
If we are finding increased nuchal translucency and we go for invasive testing, chromosomal microarray and KT came out to be normal. Even in that cases, please don't assure your patient that everything seems to be okay. And don't assure your patient that everything is normal, because there are many structural abnormality which may evolve later on. So you have to follow these cases at 16 weeks by early anatomy and early fetal echo, because increased NT, there are very high chances of cardiac malformation which you can miss in early pregnancy. If the patient nuchal translucency has resolved and you can see there is no abnormality, for vast majority it seems to be okay. But if the nuchal translucency is still persisting and there is no other structural abnormality, then you should take into account single gene disorder like Noonan's syndrome and congenital infections like Toxoplasma, CMV, and most importantly parvovirus infection.
So basically, you know, the detailed anomaly,
Ma'am,
early
we can
anomaly
take care
scan.
of the home genome
Yeah.
sequencing.
So, and
as
the
well.
fetal echo also.
And if increased nuchal translucency persists as a thickened nuchal fold in second trimester, then think of Noonan syndrome, that is a single gene disorder, and that is the importance of gene storage at the first stance while you are doing CVS. So by that DNA, you can test Noonan syndrome also.
Okay. Now tell me, a question for the core fetal medicine specialist. Now, how do you what is the difference, you know, in how do you measure NT in a monochorionic twin and in a dichorionic twin? Anyone, Dr. Vinita, you want to answer this?
NT measurement in a?
In a twin pregnancy, monochorionic or dichorionic?
Ma'am, that would be separate for both fetuses and...
I'm deviating from this case. I'm just asking, Pooja, what would you do? What?
NT would be measured in the similar manner, ma'am.
No, that is the method, but there is a difference now.
Yeah, ma'am, I would like to answer.
Yeah, sure.
In monochorionic twin, ma'am, the
Because
measurement...
this is very important, you know, for all of you to know.
They have the same genetic composition, so the risk can be given as 1. But in case of dizygotic, that is chorionic pregnancy, because based upon the chorionicity only we cannot decide, but at least we are sure that if it's a dichorionic, it can be a dizygotic pregnancy. So we have to give a risk for each fetus separately.
So basically, when you're measuring NT in a monochorionic pregnancy, the average of the two NTs is taken in a monochorionic pregnancy. Whereas in a dichorionic pregnancy, the NTs are separately, you know, it is for specific to that particular fetus. So that's the difference. Whereas in a monochorionic, you know, you will have to take an average, isn't it? Use a mic.
Is it the genetic test that you are speaking, ma'am?
In monochorionic twins, NT is used for the screening of TTTS also. Because if one fetus is having increased NT, that indicates early
because if
development
one is having
of TTS.
increased
So
NT, then either it could be, otherwise also it could be as a result of aneuploidy, or it could be as a result of early twin-to-twin transfusion syndrome. So that's why, you know, monochorionic twins can create a confusion. Right. And, you know, here the principle is that you take an average of the two NTs in monochorionic pregnancies. Okay. This is to ask you. Now, this case.
Mrs. RK, 34 years old, 11 weeks gestation, combined test shows the risk of Down syndrome 1:1:134. Would you go for NIPT or invasive testing, and why?
This patient, yes, her age is 34, having the risk 1:130. We will directly go for patient counseling is very important. If a patient wants confirmatory test, then we will have to go for invasive test.
You have to give an option.
Yes.
This is, ma'am, this is 11 weeks. We will tell her the sensitivity, the specificity. NIPT is just a screening test. And the result will still take 3 weeks to come, around 3 weeks, I think. So the result will come at 14 weeks. And if you want to get the confirmation, it will be done after 15 weeks. So we have to explain both the things, the sensitivity, the specificity, which is more accurate, and let the patient decide.
Ma'am, I would like to add,
Yeah.
rather than generalizing any outline of management, we should individualize with the patient. We should know her obstetric history and her economic background also. And at the same time, we need to address her apprehension also, how much she is apprehensive. So accordingly, what she opts NIPT or she opts invasive directly. So we have to give a holistic approach to the patient and not generalized approach to the patient.
No, so see, this is one flow chart which was propagated by Nicolaides. Now here there is one zero missing, in which he says that if it's a high risk one, which means if the risk is greater than 1 in 100, that means straight away one goes for an invasive testing. Okay. Now if the risk is intermediate, which means yeah. So in that case, one could go for a cell-free DNA testing, depending on, and if the cell-free DNA testing is positive, then you go for an invasive testing, and if it is negative, then do nothing. Because by doing this, which is contingent upon combined tests, you can actually reduce the number of invasive testings which you are doing. That is the whole, idea of...
But ma'am, this is
yeah.
good enough and fair enough, holds true for Western population. I don't agree for this chart in our population, because again, they will spend around 10,000 bucks for getting NIPT, and then if it comes out positive, still they are in a diagnostic dilemma because it is not a diagnostic test. So again, you will subject her to either CVS or amniocentesis. So for our scenario, I would request that we should counsel them that it's not diagnostic, this money is going to spend, and so go for diagnostic test.
See, Bhavna, the cost of NIPT has really come down. Now it's less than 10,000. In all national podium platforms, they're all for NIPT, although I'm not all for NIPT, but actually the cost has come down. And when they compare...
I would like to differ, ma'am.
I just wanted to tell you that when they compared all the different kinds of screening tests, like, integrated, sequential, contingent screening strategies, so what they found that contingent screening strategy had the best cost effectiveness ratio with fewer procedure-related euploid miscarriages and unnecessary terminations.
Can I speak?
Yeah,
Ma'am,
sure.
I would like to differ, ma'am. If the risk is intermediate, I would like to I'll explain about NIP because it has the advantage. Many of the patients will be screened out and very few will be required the invasive test. And always invasive test has certain risk. Even if it is 1%, the risk is there.
Ma'am, I would also like to add, regarding cost effectiveness, if we are talking the patient is coming from a peripheral center. Now we have done a combined blood test and report has come as intermediate or high risk. Directly, if we are offering for an invasive test, patient may be apprehensive regarding abortion risk or anything like that. In that case, patient may sit at home and come at a later age, gestational age after 24 weeks when we can do actually nothing. So we can offer NIPT is a way out there. And regarding cost effectiveness, the patient has to travel a lot from periphery to the centers which are actually available at capital cities, this invasive testing. So that again, travel cost, stay cost, that is adding upon. So cost effectiveness wise, if we talk, it depends upon the patient from where he is coming. And it is also decreasing the load upon all those tertiary fetal medicine center where it is being performed. Suppose directly we are offering then 10 tests, and if we are going for NIPT, then just 1 test. So the load on that center is reducing and cost effectiveness is also there.
This patient, opted for an invasive testing and it came back as normal. So that's why I was just trying to highlight the importance of NIPT contingent upon combined testing, because it can actually reduce the load of invasive testing. That's the whole idea of doing NIPT in such cases. Now,
the test has its own limitations also. And there is risk of abortion when you go for this CVS.
so because the time, I'm just looking at the time also. Now, I've just taken the liberty to go beyond the first trimester just a bit, because this patient underwent NIPT late at 23 weeks gestation. And actually, it was a twin pregnancy and with one vanishing twin. Okay. Sangam is, I think she's quite pleased to hear that. Perhaps she must have come across such a case, that's why. Now, NIPT now is heralded as one of the biggest advances in antenatal care since the invention of ultrasound scanning. Okay. So now you all know that what is the minimum fetal fraction required, and anybody, just for the benefit of the audience.
4%. 4% is the minimum.
Minimum.
And it's around 10 weeks it starts appearing, and 4% it comes. So it is ideal time. After 10 weeks you can offer any time. Though the people are advocating earlier also, but still 4% is achieved at around 10 weeks.
So is, now this patient, now if you look at the report, what you can see in red, the risk for trisomic, what was Turner syndrome, okay, it was actually high. So risk for Turner syndrome turned out to be very high in this case. So what next? I mean, would you go on this report or what?
Actually, ma'am, for
whatever the
sex
test
chromosome
results
disorders,
are just to highlight something, some practical
sex
thing.
chromosomal disorders,
Yes.
they do not, NIPS doesn't have high sensitivity for that because there will be maternal contamination, and we won't be able to comment surely that whether this is because of the fetal affection or maternal. So this is not this sex chromosome disorder should not be diagnosed or screened with the NIPS, and we should
So
not
you can
rely
see
on
on the right, see for chromosome 13, 18, 21, if the sensitivity is 99%, for the sex chromosome aneuploidies, the sensitivity has actually gone down to 90%, 93, 93. So which means that based on NIPT, definitely, you cannot come to a conclusion that whether this patient is actually at a high risk. What? Yes, yes, correct. So screening for sex chromosomal aneuploidy is considered less accurate than screening for autosomal aneuploidy, and which Sangam or somebody mentioned about maternal contamination also. Yeah, you mentioned. Okay. I think we can skip. Yeah. To ask, so see again, most of the professional organizations in the world, they're all saying that NIPT is it is more cost effective to offer NIPT only to women with an increased chance of trisomy based on their combined or quadruple screening test results. So contingent testing instead of using NIPT as a primary screening tool. So I think most of us will go by that. You'd go for combined testing, and if that is high, then go for NIPT as a contingent test rather than straight away.
And one important thing to add, ma'am, because ultrasound in the first trimester is very important, not only to diagnose to screen for aneuploidy, to screen for other structural anomaly. So we get an additional information by doing an ultrasound in the first trimester, and then depending on that, either we can go for combined or NIPS. That's again.
So what if NIPT comes back as a failed result, no call? Then what would you do?
So in those conditions, instead of repeating it, because there is an option you can repeat an NIPT, so instead of repeating, they should be offered diagnostic, because if it comes no call, there are high probability that the patient may be suffering from some chromosomal, the fetus must be suffering from aneuploidies. So better to offer them the diagnostic test, whether they go for it or not, that is the patient's choice, and individualized approach can be offered. Okay. If they say, no, I don't want to go, then we can offer NIPT again, but that is not recommended, ma'am.
Okay, so very good. A no-call result because of low fetal fraction is more likely to occur at earlier gestations with a high maternal weight, dichorionic twin, small placental mass. So if it comes back as no call, then it always raises a suspicion. So as Dr. Bhavna is saying, you could go for an invasive testing, and a lot of societies like the Canadian Society, and they're all recommending that in no call, one could go for an invasive testing straight away. Because, people sitting in the audience must have faced this problem. No call, or, the less fetal fraction. less fetal fraction also, then you have to repeat the blood test and again wait for, 10 days to almost 2 to 3 weeks. Isn't it?
If you get
So-
a no call result, the chances of aneuploidy increases to about 4%. So this is very high.
So see, so there are some common factors affecting the performance of NIPT screening. Like, in our case, it was a case of vanishing twins. So you can get false positives with vanishing twin, demise twin, then placental mosaicism, maternal cancers, maternal copy number variants, recent blood transfusion. Then you can get false negatives with increased BMI, because of low fetal fraction, assisted conception, women on biological treatments, multiple pregnancy, dichorionic, technical issues, etc. So actually, in that patient, ultimately the report came back, actually an invasive testing was done and it turned out to be Down syndrome. I think somewhere down the slides I do have that picture also. So again now, in what way is the screening performance different in monochorionic and dichorionic pregnancies when it comes to NIPT?
Ma'am, for NIPT, it is more accurate for monochorionic pregnancies because the same genetic material is being released from the placenta of monochorionic pregnancies. But if it is the case of a dichorionic pregnancy, then different genetic material, if there is one affected fetus and the other one is euploid, then the effect, the cell-free fetal DNA is being diluted by the normal one. So when we are offering this to the parent, we have to counsel and we have to make a caution that the report is not that reliable. NIPT for a dichorionic pregnancy.
So I think, Swati, you're very well prepared for the panel, I must say. I found the same in Kolkata as well.
Thank you.
Okay. So monochorionic, in fact, one would think that it would be otherwise, but it's not that way. In monochorionic twins, NIPT is more sensitive because of the same genetic material which is coming, from the two fetuses. Whereas in dichorionic pregnancies, one can go wrong because of different cell-free fetal DNA which is going into the maternal circulation, right? Because the two. And use the mic, you're telling a very important point.
Because in discordant twin, in case of dichorionic, the normal fetus will secrete more amount of fetal DNA into maternal circulation, whereas the affected fetus will secrete less amount. So there will be masking effect and there will be high chances of false negative result, and that should be considered while interpreting the result.
So just to, for this case, cell-free DNA testing can safely be offered in monochorionic twin pregnancies. Very important point for the audience. So with expected performance of screening as high as in singleton pregnancies, the test can also be offered in dichorionic pregnancies, but parents should be warned that data on accuracy are inadequate, as you all mentioned. And actually this patient, and after invasive testing, it turned out to be a case of trisomy 21. Okay. Although it was showing a high risk of Turner syndrome.
Yes, she wants to add something.
Ma'am, in cases where we are not very sure as to whether it is a dichorionic or whether we are not very sure regarding the chorionicity, then there is a provision of we can do a single nucleotide polymorphism based testing rather than going for the cytogenetic analysis, which we do from the cell extract. We can go for the SNP based microarray testing where it helps to differentiate between the maternal contamination and the fetal contamination, the maternal contamination and both the twins can be differentiated, and it also helps in the zygosity as well. So that is a newer test that is advocated now, especially if it is a twin pregnancy and you're not sure of the zygosity of the twins.
Okay, very good. So now
this SNP is not available anywhere in India. No, but it is not still not available in Indian scenario. It's being advocated. Hopefully, we'll get it further. But SNP is nowhere available in India.
So for now, it's very important, at least for now, that, we need to, when you get a case of dichorionic pregnancy, or you have to counsel the patients that, the report may not be conclusive in cases when you're doing an NIPT. Now, this case...
Now case 5 is 29-year-old doctor, Gravida 2, P0, alive 1, books at 11 weeks, requests you for an enhanced first trimester screen. Now what are the components of enhanced first trimester screen?
Including that first trimester screening, other than those, we include platelet-like growth factor and uterine artery resistance, diastolic notch, but it is not easily available. But our sonologists give uterine artery resistance, pulsatility index they give. But other placental growth factor, we have not done till date.
You have to request the lab to add PLGF. You have to. If you tell them, then perhaps some of them, like MedGenome and all, they will do it for you.
While preparing for this, I went through. We can ask them.
Okay. Just the last case, so we won't do the... So now, what is the cutoff risk that you would use for pre-eclampsia? Now in this, because what happens that with the enhanced or, I think it's the same case, no? Yeah. So this extended first trimester screen, so what is the added advantage apart from testing for aneuploidy, and also as we mentioned in our first case about fetal growth restriction, and as Dr. Sangam mentioned about preterm delivery. So apart from that, what is the advantage of doing an extended first trimester screen?
So ma'am, if we find it to be positive, if extended fetal first trimester screen, then there's a risk of even preeclampsias, etc., can be diagnosed, or at least we can understand that the patient is at risk. So we can have initiate aspirin, as the class trial says, the 150 milligram aspirin, and calcium can be supplemented in an increased amount so that such patients can be benefited, because the period from which it is advocated is around 16 weeks. So if you are not screening with this extended screening, then we may miss such patients, and then they may land up with these complications, ma'am.
Okay, so see, enhanced first trimester screen is a new FTS test that uses 4 serum markers plus the NT measurement along with maternal age. And which are the 2 serum markers? Dr. Mamta already mentioned placental growth factor, but also first trimester alpha fetoprotein, in addition to PAP-A and serum beta HCG. And a lot of centers are actually going for this. 4 serum markers in the first trimester, along with uterine artery PI, and yeah. Yes.
Right side and left side.
Okay. So, and as Dr. Khushbu already mentioned, that one would give, so what would be the proposed surveillance strategies for this patient? Now, if she's at a high risk of preeclampsia, you find so what is the cutoff for preeclampsia which you would, like,
1 in 100.
1 in 100, yes. So if it is higher than that, actually in my last case, which we are not going to take, in that, the risk turned out to be very high. But just for now, I'm asking that if the risk is high, what would your plan be now?
So we can start aspirin.
No, not only aspirin, but that means you have to be suspicious that this patient is at a high risk of early preeclampsia, which is preeclampsia before 34 weeks, right? So,
regular blood pressure monitoring, doing the
1% at a time, 1% at a time.
We will do regular, because she's at high risk, so we will do regular blood pressure monitoring at home also, urine test also, serial scan, which will be early, starting from 22 to 24 weeks. We have to evaluate the color Doppler also, and non-stress test.
So there was a comparative study of enhanced first trimester screening with the contingent cell-free fetal DNA, and what they found that enhanced FTS with contingent cell-free fetal DNA following a positive result provides a similar performance to that of primary cell-free fetal DNA at a substantially lower cost. Okay. So this study concluded that enhanced FTS with contingent cell-free fetal DNA, I just read it, following a positive result, provides a similar performance. So if you're doing enhanced FTA with the contingent cell-free fetal DNA, the performance is similar to that of primary fetal DNA at a substantially lower cost. That this was again the last case quickly, where again it was a case of bad obstetric history, where there was an IUD and one missed miscarriage, and she presented at 11 weeks. Now, being an obstetrician who believes in modern prenatal testing, you decide to go for an EFTS, which includes a preeclampsia screen apart from aneuploidy screen. So this was the uterine artery Doppler, which is you can see on the right, which was abnormal. So I think our learned panelist already mentioned that she would start aspirin. So how much aspirin? 150. Then again, so yeah, Dr. Jyoti, I think she's mentioning that. So who said 150 zyada ho jata hai? Because for our population, no, I'm asking, like, do you give 150?
Yeah, I am giving 150.
So any side effects with 150, gastric
No.
irritation or?
Not
No. Yeah, we are finishing. Okay. So apart from aspirin, then what else?
Calcium.
So uterine artery Doppler at 11 to 14 weeks of gestation identifies a high proportion of women who develop severe preeclampsia and or fetal growth restriction. Now this patient, if you see, her preeclampsia risk at less than 32 weeks was 1 in 83. Sonali, I'm just finishing. It was a very high risk. We have waited all day for this panel. So both the risk of preeclampsia before 32 weeks and before 34 weeks, it was very high. 1 in 83 and 1 in 37. So what next? Low dose aspirin, how much and for how long? Now how long would you like to give aspirin?
Till delivery. Till delivery.
Till?
Delivery. No,
Okay.
till delivery.
Okay. Now, no, but what about 36 or up to... So see, aspirin is not associated with a significant increase in placental hemorrhages or in bleeding during preparation for epidural, but there was a slight increase in use of blood transfusion after delivery. Now, if you ask my personal opinion, generally if I'm anticipating that, this patient may need an emergency delivery beforehand, definitely, I try to tell them to stop the aspirin at least 2 to 3 days in advance.
35 to 36 weeks, उसके बाद हम लोग नहीं देते हैं.
नहीं, but Mamta, what if you think कि इस patient का करना पड़ जा सकता है because there
because
is
of
fetal
VOH
growth restriction.
Yeah.
Can be given, but you are not sure कि कब labor में चली.
Yes.
So it's better कि आप 36, 37.
But what I have experienced that while making the incision over the anterior abdominal wall, they generally, the small bleeders and all, they generally have a more tendency to bleed. Some things are bookish, okay? Now they are even saying that you can give aspirin till 40 weeks, isn't it? There's no harm. But when you actually face, and I have faced this problem many times, that these women, especially, it does become a bit cumbersome when you are opening the anterior abdominal wall. So, and how much calcium? How much calcium quickly?
At least more than 1 gram.
Okay. And would you like to do a routine growth scan and umbilical artery Doppler at 32 weeks?
Yes.
Okay. So just to sum up for this case, so what all? Aspirin? Okay, so...
High
Dr.
dose of
Mamta?
calcium.
Yeah.
And Doppler monitoring after 32 weeks. for IUGR, and it will we can detect even early onset eclampsia, pre-eclampsia also.
So actually, this was the last question, and I hope you people have enjoyed the panel.
Yes,
because
yes.
these were just, some take-home messages, that also I'll skip because we are getting reminders. So thank you all esteemed panelists and viewers who have stayed till the end till 5 o'clock. Thank you so much.
Thank you, ma'am, for
Only the theoretical aspect, but shared the practical aspects also. I request Amita ma'am and Vinita ma'am for the valedictory session.
Came to the end of scientific session, and we are here for the next session, which is valedictory. On behalf of valedictory team, once again, I welcome you. But especially this session is to acknowledge the sincere efforts of our organizing team, review our work, take feedback from the delegates and faculties, and thanking each other. We all know that the fragrance of flowers spread only in the direction of wind, but the goodness of a person spreads in all direction. So with this quote, I would like to invite organizing team on the dais. At the outset, I request Dr. Rita Sinha madam, patron Dr. Manju Geeta Mishra madam, Dr. Zareen Rahman, Secretary, Organizing Secretary, Patna Parb, बस इतना ही रहने दीजिए डॉक्टर प्रज्ञा बुला रहे हैं I request scientific chairperson Dr. Abha Rani Sinha madam to kindly take a seat on the dais. Joint secretary को भी नहीं बुला रहे हैं ना जो लोग कुछ बुलाना है जल्दी बताइए इसीलिए नहीं बुला रहे हैं Dr. Rita Sinha madam, organizing chairperson, please come on the dais. और चार तब उनको भी बुला लो तब हिमाली दी को भी बुला लो to kindly take a seat on the dais. बुला लिया है ना अच्छा ठीक है अभी तो इनकमिंग प्रेसिडेंट है अभी इनकमिंग प्रेसिडेंट है मैडम ठीक है अभी चेयरपर्सन से बुला रहे हैं अब
Rest of you, can you please come up in
Dr.
front?
Vinita,
all of you can come in front.
Kindly present a saplings to all the dignitaries sitting on the dais as a token of love and the way for thanking
Bhavna,
them.
come up.
Present a sapling to our Joint Secretary Dr. Poonam Lal, Dr. Jyoti Malhotra and Dr. Bhavna Tiwari. दीजिए और दीजिए। चलिए, sapling दीजिए और sapling इधर लाइए। कि वैलिडिटी कमेटी को मैं दे रही हूँ नहीं तुम हो क्या किस चेयरपर्सन इन एब्सेंस ऑफ को चेयरपर्सन
Now I request Dr. Vinita to Dr. Poonam Lal to give the sapling to Dr. Amita Sinha because she is in the valedictory committee and Chairperson Dr. Rita Jha, she is not here. So I request, Rita Jha is not. So please Dr. Poonam hand over the sapling to Dr. Amita. तुमको किससे दिलवाना है? ठीक है. Thank you, Dr. Poonam. Now, please, next is Dr. Vinita, our treasurer of Patna Parb ISOVA, to please, co-chairperson valedictory also to hand over the sapling. Thank you, Poonam.
As I told earlier, that fragrance of flowers spread only in the direction of wind, but the goodness of a person spreads in all the direction. So I request patron Dr. Manju Geeta Mishra Madam, who is the backbone of this conference, to give her feedback so that we can improve ourselves or we can review our work. Madam, over to you.
Thank you, Dr. Amita. First of all, I must congratulate the organizing chairperson, Dr. Rita Sinha, and organizing secretary, Dr. Jareen Rahman, for organizing this conference in such a grand way. So please give a big, because in such a short notice, and this is this was the first conference which was organized by Patna chapter, and it was like annual conference of POCs, not less than that. So I congratulate them. Everything was very well managed. The hall was full, so that the main credit goes to the chairperson and the secretary, who has called so many, because even after lunch, the hall was full. So I think more than 200 registration. Kitna registration hua hai bhai? 250. So 250 registration was there. So, and so many speakers are there from outside. And I must thank the pharmaceutical company, because only on short notice they have helped us, and because without their help, as we all know that without the help of pharmaceutical company, we can't hold any conference. And the success behind any conference is the support, indirect support, or you can tell direct support by the pharmaceutical company. So I must please. So only on very short notice, all the pharmaceutical companies, and there was some notice from the center that no company should give any help to प्रज्ञा को बुला लो जा नहीं तो सुधर जा रही है हाँ तो बोल देते हैं. So after that, from National Medical Council and from the center, some hue and cry was there. But in spite of those hurdles, the pharmaceutical company has come forward and helped us. So I must thank them from core of my heart, because without their help, no conference can have success. So I must thank you all the pharmaceutical companies who has helped us in such a grand way. Thank you very much. And I'm coming from the start, the inaugural session. कौन था उसका सर ये सबका याद नाम नहीं याद है तो नाम नहीं याद है और so first inauguration was done in a grand way, and the Supriya, Mini Anand and Lakshmi Jha, they were the convener, so they have done the inauguration in a grand way, and it was done successfully. Even after inauguration, the scientific program was very well organized, and all the scientific sessions were in time and was good. So I must congratulate the chairperson, scientific committee, Abha Rani Sinha, for making this program in such a nice way. And food committee, chairperson food committee, food was, in spite of the fact that they did not expect that so many so many delegates will come. But I think most of the delegates have taken their lunch, and lunch was delicious. So, so lunch was also very good, and I think even in spite of a paucity of space, the pharmaceutical company have got their space in the Kesaria Hall. So I think, but I was very much pleased because I didn't have any hurdle in moving around the stalls. I went to all the stalls and visited all the stalls because it was very easy, and there was no difficulty in the hall. So all the pharmaceutical company got some space. So once again, I thank all the chairperson, especially the president, Patna chapter and secretary, who have taken keen interest and organized this conference. So please give a big hand to all the members of Patna Parb who have organized this first conference in such a grand way. Thank you all.
Thank you, madam, for your valuable feedback and appreciation. Now I request organizing chairperson, our outgoing president, Dr. Rita Sinha, madam, to give her valuable feedback.
Supervision of Dr. Manju Gita Mishra, my secretary, Dr. Zari, all my team members, and Abha Rani Sinha, my, not name, but my sister. So I have enjoyed very much. And all the senior members, national, Dr. Pragya, Dr. Usha Sharma, Dr. Meena, everyone, and other seniors has given blessing to me, and I have enjoyed very, very much. And I am very much happy that I have given my charge to Dr. Himali, who will do very hard work, and this ISOPAR will reach to a very, very, very height. And I think that Pragya is waiting for a beautiful, constructive perinatology ISOPAR building. So I think that it will happen in future. Long live ISOPAR. Long live ISOPAR.
Thank you, madam, for your blessings. Now I request our scientific committee chairperson, Dr. Abha Rani Sinha, madam, to give her feedback.
Thank you, Vinita. First of all, I would like to apologize for not being active in this conference, because I give the whole credit of this scientific program and the conduction of the scientific thing to my two very dynamic chairpersons, Dr. Monica Anand and Dr. Sangam Jha. I think they have done the biggest job. supported by Dr. Zareen Rahman, Dr. Rita Sinha, Dr. Jyoti Malhotra, Dr. Bhavna Tiwari, Dr. Vinita Sinha, and Dr. Poonam. I think they all have worked and under the supervision of Dr. Anjana. Dr. Anjana is senior to you people, but you guys, you have made really, they have worked hard. Everything, whatever instruction I was giving in tits and bits, they were just joining them together and they worked really very hard. And now I know that now I haven't to become the chairperson. You people can now guide the whole scientific committee. They have done a great job, so well done. Well done, scientific team.
Yes, thank you, madam. Really, scientific team has done a wonderful job. And we want to thank both the co-chairpersons, Dr. Sangam and Dr. Monica, by giving simple saplings. Very pretty and simple saplings. Now I request Dr. Zareen Rahman, madam, to say a few words. कौन बोलेंगे? अच्छा प्रज्ञा, ठीक है. नहीं हम बोल देते हैं, प्रज्ञा दी को बोल देते हैं. I request Dr. Pragya, conference coordinator, to say a few words, please.
Thank you, Amita Di. But before I start speaking anything, I would like to congratulate you for Dr. Amita Sinha. I would like to congratulate you for the award which, because of your efforts,
so much,
came
Pragya.
to Patna Obs and Gynae Society. Yeah. So. Overwhelmed that this annual conference of ISOPAB has actually took place and it was a grand success. Dr. Rita Sinha was so tensed about this conference, and especially the NMC rules which came just at the peak time when people were planning to hold this conference. But what they say, that all's well that ends well, and the pharmaceutical companies have actually come together again in our support for this conference. So, and I would really convey my heartfelt gratitude to the pharma companies this time, that because of you all, this conference has been really successful. Okay. Secondly, I mean, as Secretary General, I had been to Dibrugarh, to Guwahati, and to other places also where they were holding annual conferences of the city chapters. And actually, I was also hoping and wishing that Patna chapter also holds a conference. So today is the day when Patna, when it all came out to be true. And it all turned out to be true because of the efforts of Dr. Rita Sinha, Dr. Zareen Rahman, and with the constant support of Dr. Manju Geeta Mishra. And I would just like to say that as Secretary General of ISOPAB, the whole Patna chapter, the team, has made me feel so nice today. They have given me so much of honor and so much of privilege during the inauguration that I just cannot express in words how I felt. So I really felt like, sometimes, if you belong to that place, they don't give you much importance. But Rita Di and Dr. and the whole team, they continuously made me feel that, I'm the Secretary General of National ISOPAB. So thank you so much for that. And it was a real nice, warm and hospitable conference. Dr. Kushagrati Ghosh said, "Oh, I love coming to Patna. You people do so much and make me feel so wanted that I feel like coming to Patna over and over again." So thank you so much. And Dr. Supriya Jaiswal did a wonderful job during inauguration today. She convened the inaugural ceremony. That was a great show, and keeping up to the time margins also. So it was indeed a very good inaugural ceremony today. So thank you so much. And
yes. Thank you, Pragya. Now, few words from Dr. Zareen Rahman, Organizing Secretary.
Thank you, Amita. Actually, I am overwhelmed. At the same time, I am very relaxed.
I think for the last 15 days I did not sleep well. After coming and enjoying from Canada, when I came back, I thought it will be cancelled because of the NMC rule. But madam, right from the beginning, she was saying, "Hona hai, karna hai tum log ko. अब जैसे भी है तुम लोग को करना है." सो उसके बाद तो हम लोग लग गए, पूरा टीम लग गया हम लोग का, और हम लोगों को बहुत सपोर्ट मैडम से भी मिला, डॉक्टर रीता सिन्हा, और एवरीबडी हेल्प्ड अस इन फैक्ट, एंड थैंक गॉड काफ़ी सक्सेसफुल हुआ. वी नेवर एक्सपेक्टेड सो मच डेलीगेट्स, सो मेनी डेलीगेट्स, इतना अच्छा साइंटिफिक प्रोग्राम. फार्मा कंपनी दे हेल्प्ड अस अ लॉट. मतलब हम लोग 5 या 6 स्टॉल्स एक्सपेक्ट कर रहे थे, बोलते भी थे मैडम से, मैडम 5 स्टॉल हुआ है, 4 हुआ है, मैडम कैसे होगा. बट इवेंचुअली हाँ, करो ना, हमेशा यही बोली, करो ना, तुम लोग ऐसे क्यों बोलती हो. हाँ हाँ, एकदम पॉजिटिव. हम लोग नेगेटिव नोट में जा रहे थे, ये पॉजिटिव नोट में. और मेरा तो ऐसा था कि 3 बजे रात में उठ गए और वेट करते थे कि 5 बजे, और रीता दी को फ़ोन करते थे, रीता दी कैसे होगा, कुछ भी नहीं हुआ है अभी. हाँ तो बोली हम भी तो नहीं सोए हैं. सो इट वॉज रियली टफ टाइम फॉर फ्यू डेज, बट देन एवरीथिंग वॉज स्ट्रीमलाइंड, एवरीबडी हेल्प्ड अस. माई जॉइंट ऑर्गेनाइजिंग सेक्रेटरीज वर वेरी हेल्पफुल, दे डिड अ गुड जॉब. रीता सिन्हा मैडम तो एकदम ही बहुत, मतलब मेन बैकबोन वॉज मैडम एंड डॉक्टर रीता सिन्हा. और मेरी हाँ साइंटिफिक पर्सन पीपल, डॉक्टर आभा रानी सिन्हा हमेशा बोल रही थी हम कुछ नहीं कर रहे हैं, बट इट वॉज नॉट लाइक दैट. पूरा सुपरविजन था, साइंटिफिक ग्रिड दे हैड मेड, एवरीथिंग दे हैड मेड. इनॉग्रेशन वॉज फैबुलस, बहुत मज़ा आ गया. एंड रजिस्ट्रेशन वॉज रोबस्ट, काफ़ी रजिस्ट्रेशन हुआ, ऐसा नहीं था कि कुछ नहीं हुआ. और वैलिडिक्ट्री भी तो अब देख ही रहे हैं, बहुत अच्छा हो रहा है. एवरीथिंग वेंट फाइन.
हिमाली दी,
बैग्स, मोमेंटोज, सब में हर्डल्स आता गया, लेकिन सब कुछ स्ट्रीमलाइन होता गया. सो ultimately by the help of God and by the hard work and dedication of whole team and the backbone thing, I mean madam was the backbone, everything went very smoothly, and I am really happy that it was a very successful and dazzling.
And one thing that, see, we have learned, Dr. Rita Sinha and Dr. Zareen Rahman wanted to do a 2-day conference. I was the one who said, you know, I kept on insisting, why can't we do a 1-day conference? And actually today, like, you know, we should learn that even 1-day conferences can be very successful. It does not have to be a 2-day conference where people get so saturated by the end of 2 days.
नहीं, इसका हमको अफसोस है. मैडम चाह रही थी कि 1.5 दिन का हो, बहुत बार बोली हैं तुम लोग नहीं कर रही हो, हम कितने दिन से बोल रहे हैं. तो वो एक चीज़ हम लोग नहीं कर पाए, इंस्पाइट. हाँ,
अच्छा, हमारी इधर की सब बहुत काम की है.
यस, एक बार आप जॉइंट सेक्रेटरीज तो सारे के सारे बहुत लोगों ने अच्छा किया.
जॉइंट सेक्रेटरी लाल राइट एंड लेफ्ट थी एकदम.
हिमाली दी, वुड यू लाइक टू से समथिंग? नो, ओके, देन विद दिस.
अच्छा, एक कमेंट और हो रहा था हम लोगों पर कि सब नए नए लोग को ले लिया गया है, कैसे होगा कॉन्फ्रेंस. बट इट इज़ नॉट लाइक दैट कि हमेशा मंझे हुए लोग को लो, नए लोग को चांस देना है, उनसे करना. एंड ऑल आर इंटेलिजेंट, दे फॉलो इट. सो इट्स नेवर लाइक दैट कि
नया खून है, नई उमंग है, फिर भी है, मतलब इनका तो है
हिंदुस्तानी. तो ये एक पॉजिटिव सीखना है.
अभी माली दी बोलेगी.
मोमेंटो बहुत ही अच्छा था.
मैडम
I
रीता
must
सिन्हा
congratulate the organizing team
मैडम
of
रीता सिन्हा ने गधे को भी घोड़ा बना दिया. मैं इस फील्ड में कभी नहीं आई थी ऑर्गेनाइजेशन में. रीता सिन्हा मैडम ने बोला नहीं तुमको करना ही है, हम नहीं जानते, मेरा कॉन्फ्रेंस है, तुमको करना है. मेरे हस्बैंड बोले तुम कहाँ चढ़ रही हो, ये सब तुमसे थोड़ी होगा. उन्हें रीता मैम ने मुझ पर विश्वास किया, तो मुझे कुछ करके दिखाना है. तो हर चीज़ रियली इंजॉय किया मैंने, मोमेंटो बनाना या सर्टिफिकेट साइंटिफिक जो भी हुआ, और अच्छा ही रहा. थैंक यू मैम. सर मंजू गीता मैम के हम लोग 2 बार गए, आज तक मैं गई नहीं थी, 2 बार गया. वी एंजॉय एवरीथिंग रियली. थैंक यू मैम फॉर
Yeah, it's almost 6 o'clock. I think I must congratulate the organizing committee for a very wonderful conference, and they've set the bar very high in the last 2 years. So I think the task before my team is going to be very daunting.
Yes, thank you.
Thank you, and I hope we
Supriya,
live up
two
to
words.
it.
Supriya, two words
Thank
from
you.
your side.
So I'm also very much overwhelmed that I got the opportunity to do the inaugural function, and I'm very happy that the backbone is Madam Manjugita Mishra. She said you have to do it properly, and Pragya Di endorsed it, that I did it successfully. So thank you so much. The whole team was wonderful, and I really thank everyone. And one word, that really we thank the pharma companies, that even in the Kesaria Hall, the show was very good. And thank you everyone. Thank you Zareen Di and Rita Di especially. Thank you everyone.
Yes, thank you, organizing team. We will remember this memorable, knowledgeable, and remarkable conference, one-day function of ISOPAV. So on behalf of Patna Parb, we sincerely thank you all for being with us in this late evening. Thank you once again. As we know, life is like a balloon. If you never let yourself go, you will never know how far you can reach. तो इसीलिए हम पूछेंगे, जब तक जैसे पूनम ने कहा कि अभी तक हमने नहीं किया था, लेकिन एक बार आप लाइफ को बलून की तरह बना ले, देखिए आप कितना ऊपर जाते हैं. And with this quote, I invite everyone to catch up this balloon, and everyone, Mamta, Pratibha, scientific team, Pooja, everyone, Sajia. Yes, मेरे को आने दो, मैडम मैडम आ रही हूँ सब लोग आइए. And 3 cheers for this ISOPAB conference one day. Hip hip hooray, hip hip hooray, hip hip hooray. Long live ISOPAB, long live ISOPAB, long live ISOPAB. छोड़ दें, okay, yeah. Ready, 1, 2, 3, live it, live it, live it, live it. Give a big hand. Story never ends. Now we are going to start a new beginning with new President Dr. Himali Sinha, and hope we all will enjoy next year annual conference under her leadership. And life never ends. Yeah, yes, sure. A new team. Also, I congratulate whole new team at the end of this function. Okay. All the best for next year.